Good morning, everybody. On behalf of my organization, Institute of Medicine and Law, I, Ravindra Mangal, the Executive Director, take this opportunity to extend a warm and hearty welcome to all our esteemed panelists who have made time from their extremely busy schedules to discuss and deliberate on this very hot topic, that is violence against healthcare providers. We already know the issues, and we are here today to find solutions to these issues on this beautiful Sunday morning. At the same time, I would also wish to welcome all our viewers who are watching this live broadcast. All of us know that bringing about change or correcting things which are not right is not an easy task. But change we must, not only to stay relevant, but simply because that is how things progress. We at the Institute of Medicine and Law embarked upon this journey in the year 2015, when we had our first national convention, conducting 3 separate breakaway sessions on 3 different contentious legal issues troubling the healthcare providers. And since then, we have identified many more issues and conducted this event every year. Unfortunately for us, unlike the early years, when the events were conducted in physical locations, like at the Nehru Center, Hotel St. Regis, MNLU, and so on, this year, as last year, we are forced to conduct this event virtually, wherein the deliberations and debates may not be as intense as in person, yet we will try to achieve the maximum out of this convention by bringing out the best from our esteemed panelists with the help of our talented convener, Dr. Gopu Krishnan Pillai, and our brilliant moderator, Dr. Parag Rendani, who has supported us superbly many times earlier. Please allow me a minute or two to explain what we are trying to do here. The convention brings together the 3 key stakeholders required for change. That is the policymakers who make the laws, the healthcare providers who are facing the issues, and the judiciary to provide the legal framework within which the laws may be amended. The idea here is not to simply discuss the issues, but rather to find out practical solutions through these deliberations. These ideas are captured and documented in a white paper, which is then circulated amongst the concerned stakeholders for making the necessary changes or amendments. We are indeed proud to inform you that some of the ideas that we discussed in the previous editions, like the uniform determination of brainstem death, which was probably discussed, I think, in 2015, and in which I believe one of our most important well-wishers, Dr. Ved Prakash Mishra ji, and even Dr. B.K. Rana were present. The idea for virtual autopsy, which we deliberated in 2018, in which Justice Sri Ravi Tripathi ji, another ardent well-wisher, was present. These are going to be accepted soon. I am neither trying to claim credit for their implementation, nor am I saying that it happened because of us, as there are many, many players involved besides us who have been pushing for these changes. But certainly, we are also at the forefront demanding change. It is indeed an honor to have such a superb lineup of panelists, and I'm quite sure that we are going to witness something spectacular today. With these few words, I would now like to invite the chairperson for this session, Dr. Ravi Wankhedkar, who has not only graciously given his valuable time today, but has also provided us many inputs for this session. Dr. Wankhedkar happens to be the treasurer of the World Medical Association. He is the former president of the SARC Medical Association, former national president of the Indian Medical Association, and honorary professor of surgery at the SBH Government Medical College, Dhule, Maharashtra. Dr. Wankhedkar, I request you to formally open this session and also provide us with your keynote address. Over to you, Dr. Wankhedkar.
Thank you, my dear friend, Dr. Mangal, and good morning to all the guests and the learned panelists. My today's convener, Dr. Pillai, and the moderator, Dr. Indani, who I am seeing after a long time, all the esteemed panelists, whom I always call the fifth Veda of medical education, Professor Emeritus Dr. Ved Prakash Mishra sir, Dr. B.K. Rana, the National President of IMA, Professor J. Jailal, the guest of honor, the Honorable Member of Parliament, Dr. Watts, who has been supporting the cause of the medical fraternity in the Parliament since long, and we have a long association with him, Professor Russell D'Souza, all the other esteemed and learned panelists and dear friends. First of all, let me congratulate Mr. Ravindra Mangal and his entire team for taking up this very burning issue of violence against the healthcare providers. And I like the idea that today we are going to discuss the solutions of it. That is very important. And with such a galaxy of panelists coming from all walks of life, or rather all stakeholders, I'm very sure that definitely some sort of solution or solutions will come out of today's deliberations. We at Indian Medical Associations or even at the World Medical Associations have been trying to deal with this problem, which has become a worldwide phenomenon. It is not limited to our country itself. A country like China, an advanced country like Israel, where a nurse was burned down by the patient's relatives. And it is happening now everywhere. Basically, this is a social problem. It is not only a legal solution. Only a legal solution, if it was there, then 23 states with quite a stringent law should have tackled this issue. But there are multiple dimensions to it. Right from the side of the, let us introspect ourselves also as a healthcare providers. What is wrong with us? There are issues, systemic issues, especially in government hospitals. There are legal issues. There are issues of the psychology of the patient and their relatives. All these factors combined together have created this monstrous problem. And hence, today, I am very, very hopeful that with such a panel, definitely some solutions we will be able to suggest. We at Indian Medical Association have always been very, very vocal in demanding a central legislation and changes in the IPC so that there should be a uniform law throughout the country, and also making changes where certain sections, for example, have to be made a punishment of more than 7 years so that the section becomes non-bailable. And we are hopeful that in the current session or in the coming few months, we may be this particular central legislation, which has been already forwarded by the Health Ministry to the Law Ministry, will see the day of light. And such conventions going to the general public and making them aware that this is not our problem. This is the problem of the patients which are and their relatives who are going to face. We saw a sea change of defensive medicine once Consumer Protection Act was introduced. And now with the always a looming threat of violence. I mean, it is as simple as that. You can't point a finger, pistol at my or revolver at my temple and ask me to do a treatment, especially for a serious patient. And this is not a new problem. It is said that the great Alexander, when he was suffering from malaria, probably that time, no king's physician was ready to treat him because they were afraid that if anything goes wrong, they will be executed. So the Alexander the Great had to come out with a royal decree saying that if anything happens, still this physician should not be troubled. And thereafter he was treated. So this problem does exist since long. There are, as I said, there are multiple socio-economic, psychological factors. And another thing which I would like this panelists to deliberate and to give output is one big socio-emotional issue which I have been noticing as a medical teacher. The parents who want their children to go to medicine since 9th standard, they make them asocial. Asocial, again I will repeat, where they are not allowed to watch TV, not taken out anywhere, no relatives are allowed inside, and till the time he enters the medical institution, that is 4 years, his emotional quotient does not develop. Like everybody of us understand that adolescence is a phase where physical changes occur. Similarly, psychological and emotional changes also do occur. And this young boys and girls which I am seeing in medical colleges are emotionally asocial. They are unable to deal with stressful conditions, which as a doctor or as a healthcare provider, we have to deal day in, day out. And then the flashpoint becomes very, very bad and may result in violence. So this is another issue which I needed to flag off. I officially declare this convention open and hope that next 2 or 3 hours we will have a very, very good Amrut Manthan and Amrut will come out for this wish of violence. Thank you. Jai Hind, Jai IMA.
Thank you very, very much, Dr. Wankhedkar. That was very crisp, very clear, a great start for the convention. Taking forward your example of Napoleon, let me just read out a very small sentence which I picked up some time back. And it says, and I quote, "No physician, however conscientious or careful, can tell what day or hour he may not be the object of some undeserved attack, malicious accusation, blackmail, or suit for damages." And this paragraph from a reputed journal from the USA was written 135 years ago. It is not only an eye-opener, but it is also prophetic. Let me now call upon the convener of today's session, Dr. Gopu Krishnan Pillai. Dr. Pillai has a clinical background in geriatrics and palliative medicine. He is currently working as a senior public health specialist with Swasti Health Catalyst, which is a USAID and UN partner nonprofit. He has worked as a doctor in various settings, government, corporate, and nonprofits, both in rural and urban settings, and has developed a serious interest in the subject of violence and harassment faced by the healthcare providers. His research as a candidate in the international course in health development at KIT Royal Tropical Institute, Amsterdam, looks for systemic causes that lead to the distrust between doctors and patients, the circumstances under which it leads to violence, and the implications of the same for the health system in countries like India. This has enabled him to not only have a comprehensive grasp of this very complex issue, but also to identify practical solutions that could potentially benefit both the healthcare providers as well as the public at large. Dr. Pillai, over to you, sir.
Thank you, Ravi sir, for that kind introduction. And hello, esteemed panelists. It's really an honor and a pleasure to be here with you. Let me quickly share my screen. So what I have tried to do in the limited time that I have for this opening remarks is to try and put together certain visuals that help us think about the human impact of this complex challenge that we are deliberating upon today. And these visuals are from real incidents in the recent past, but they are not of the same incident. But they represent a chain of events that I'm sure will be all too familiar with to all of us in this room. So what happens? They are perceived. Okay, let me put on my screen. Okay, yes. So what happens? Ravi sir, this is full screen and everything is good. Okay, thanks. So yeah, so there is a perceived injustice, and I say perceived because it is to be deliberated upon and for the legal system to determine if an injustice has occurred or not, given the complexities of how medical practice works. But some people literally take their grudges to the grave, as we can see. A mob is formed, hospitals are vandalized, healthcare providers are assaulted. Now, even during, many of us will be familiar with this because this is quite recent. Even during COVID-19, on the one hand, petals are showered upon doctors. On the other hand, this is happening. So this happens. The aftermath. Doctors go on strike. And in many cases, because it is also at the height of COVID, and the mostly striking doctors are the ones who are keeping the system running. So the government has to threaten the doctors to come back to work. And where does all of this lead to? This. The ultimate victims. The ultimate victims are the poor and the vulnerable segments of society. Now, this lady with her child who may have traveled from God knows how long and how many kilometers away has nothing to do with any of this. But she is the one who is the ultimate victim of this process. Keeping that in mind, keeping the human tragedy in mind, let us look at a brief snapshot. And Dr. Vankhitkar already touched upon many of these topics. And this is exactly what my own research has corroborated, that this is actually a big problem. The global health workforce is one of the largest workforces in the world. And 70% of the health workforce globally, and this is true of developing countries, of developed countries, they experience violence. And the violence tends to be both underreported as well as understated. Now, by understated, what I mean is incidents that would in a normal setting be considered as grievous violence tend to be reported as simple violence. Incidents that would be considered as simple acts of violence are not reported at all. So even the 70% in that sense might be an underreporting. And when we say violence, just to be sure, it involves not only physical violence, but verbal, emotional, and sexual violence. The consequences for the survivors feel helpless, they feel humiliated, they feel shocked, surprised. They become hyper-vigilant, always expecting when and where the next assault is going to come from. And this is true even if one is not directly the survivor, only one knows about someone who has had it, a professional colleague, the hypervigilance still happens, especially in the age of WhatsApp groups. Survivors feel anxious. In fact, nearly 40% of them are, believed to meet the diagnostic criteria for PTSD. And with good reason, because in as many as 1 in 20 cases, it leads to life-threatening injuries. And in one study, it was 3%, 2 to 3% death. So this is not a small issue. What else do they feel? Survivors also feel mistrust and fear of patients in general. And as Dr. Vankhitkar mentioned, under stress, medical errors happen. And there is defensive practice, overemphasis on risks and documentation. And doctors don't stop taking risks on behalf of their patients. The Alexander story very poignantly brings out, if the doctor cannot take risks on the behalf of their patients, then the patients suffer and the system suffers. Doctors work to rule and nurses work to rule, which means they do the minimum required that they can't be held liable. But again, the quality of relationship and the quality of care suffers. And at a systemic level, because the law and order system is supposedly stronger in cities, the perception is that it's stronger in cities, there is attrition of doctors from rural areas, especially in high-risk domains of practice such as critical care, obstetrics, and gynecology. So where you need the most, where you have the most need for healthcare providers, you have them the least available. Also, when there's a high attrition of doctors, there is obviously the continuity of care is not available. The hospitals in rural areas will have to circle through and kind of revolving door of doctors. All of this affects marginalized communities and vulnerable individuals within those communities who cannot go to the cities and get the care they need. So this is an equity issue. This affects vulnerable segments of society disproportionately. And this is what makes this a public health issue. So this is a law and order issue, yes, but this is an even bigger public health issue. Because no matter how many new doctors come out, how much our investment increases, by the way, which is one of the poorest in the country, unless we can get the right resources and the capital to flow to the areas of the country where we need them, rather than getting over-concentrated in the few cities which already have them, we are not going to address the problem of equity, quality, and safety of care or access and coverage in this country. So what we need is a paradigm change. And I would leave it to the room to deliberate whether this is rightly or wrongly, but there is a perception among doctors that society at large is indifferent or even hostile towards them. And this perception is growing, especially among junior doctors. Strikes are seen as the only way to force policymakers or the legal system to respond. And the more disruptive the strike, the better. But again, as has already been mentioned, despite the more stringent laws, assaults have continued. And I don't think there has been a single conviction. Please correct me if I'm wrong. I'd be very happy to be corrected. But I haven't been able to find a single conviction in any of the new laws that have come out. And what I feel personally is that strikes, so on the one hand, we have seen that they don't lead to solutions because the problem has continued. I don't believe they address the root causes of the problem, which lie elsewhere. And I actually believe healthcare strikes add to the problem because it creates and it continues the narrative of doctors versus society. Because I don't see this as a problem of doctors or nurses. Healthcare providers include both doctors, nurses, and others versus society. I see this as a problem that affects both doctors and patients and the society at large. With that, I end my remarks and I invite the panelists to deliberate. Thank you.
I am happy to announce that we have Lieutenant General Dr. D.P. Watts amongst us. Thank you, Dr. Watts, for joining us for this convention.
Thank you, Mangal sir.
Okay. If I could have your few words before we start with the thing.
First, though, I must congratulate you and thank you for organizing such a conference which deals with day-to-day problems of practicing doctors, government doctors, and everybody. Consumerism is like a Damocles sword hanging on the neck of professionals, but partially it was addressed also. Amended in the parliament. And I was given to understand by late Ramvilas Paswan that this service has been exempted from it. But I still see the cases. That means there is something in between which is still troubling us. Now, to be very frank, I am attending a parallel function of my party which clashes with this. Now from my vehicle, I am speaking to you. So you carry on with this. I am with you. We will in parliament. Yes, it fully means whatsoever are the lacunas. And I had passed on some Supreme Court judgment about some Bombay High Court case also, which goes in the favor of doctors and hospitals. I wish this conference all the best. And as I am attending another function also. In between, I will be joining. 10-15 minutes, I may be away. Thank you very much.
Thank you for a kind word, Dr. Watts. Dr. Watts, I am sorry I was not able to introduce him properly. Dr. Watts happens to be an honorable member of parliament. He is the former chief of the Haryana Public Service Commission. He is himself a noted ophthalmologist and the HOD of Maharaja Agrasen Medical College, Hisar. I would now like to invite our...
One more thing, I have remained Director Armed Forces Medical College, Pune.
Wow. Okay. I'm sorry. Thank you so much, Dr. Watts. I would now like to invite our moderator, Dr. Parandani, who happens to be the CEO of the Wockhardt Hospitals Limited for Maharashtra. He is a former member of the technical committee of the National Accreditation Board for Hospitals and Healthcare Providers. He is also a principal assessor for the National Accreditation Board for Hospitals and Healthcare. Over to you, Dr. Indani. From now, you will be taking charge of... Yes.
Just before Parag takes over, welcome, what's up? As I mentioned, that Dr. Watts has been a great hardcore supporter of Indian Medical Association. Whenever we approached him or whatever we member of parliament meetings we organized for last 3-4 years, Dr. Watts has been there and on the forefront in supporting the movement for the fraternity. Once again, welcome and thank you, what's up.
Thank you, Daksa.
And Mr. Dr. Pillai, there has been a lot of convictions. I can send you the list, including in my own town under the same act when goons vandalized the ICU of our medical college hospital. They were sentenced for more than 2 years of jail. Thank you. Over to you, Parag.
Thank you very much, Dr. Wankhedkar, Ravindra. It's a pleasure and an honor to be here, though the topic is quite morose. It is defeating in itself when on one hand, as Dr. Pillai and Dr. Wankhedkar mentioned, we're talking about petals being flowered, Prime Minister himself supporting, respecting the healthcare fraternity. On the other hand, I think the pandemic has seen more of healthcare violence as compared to before, because what has come out is the actual state of Indian healthcare in multiple shades. It's very important for us to realize that as we go ahead, and I'd probably like to dwell on 5 major questions, which I have myself picked up from the Internal Medical Research, an article in August 2018 by Ghosh, where she clearly writes, what can a doctor do to avoid violence? What should hospitals do to avoid violence? What should the family and society at large do to provide violence that they themselves initiate? What is the responsibility of the media? And what is the responsibility of the government and political parties? Now, I'm not going to point any fingers here. We have a very esteemed group of people who are going to be answering this. The way we are going to run it is, since we're already running a little late, we will be giving each panelist about 4 minutes. At about 3.5 minutes, I'll be saying time, just one word, so as not to disrupt your flow. We then have another 2 to 3 minutes in the second round, where each one of you will be given an opportunity to contribute to the discussion. The good part about this is that we're all aligned in the right direction and we're all focused on getting the right thing and to ensure that healthcare in this country actually sees the epitome of success that it should, the respect that it deserves. And here, remember, ladies and gentlemen, we are not restricting ourselves merely to doctors. We're talking about all healthcare workers, whether it's in the private sector, whether it's in the public sector, whether it's a doctor, a nurse, a healthcare professional who is not a doctor or a nurse. And that's the focus that we'd like all of you to address. I'd like to begin this conversation by giving due recognition to each one of you here, and starting with Dr. Ved Prakash Mishra, who's Principal Advisor to Honorable Chancellor Kim Skarad, also Pro-Chancellor of Datta Mege Institute of Medical Sciences, Nagpur, National Head of the Academic Program, the UNESCO Chair in Bioethics, Haifa. Dr. Mishra, I'd like you to start and tell us about what is the burden of this problem and what should we be doing, your contribution on what is the correct thing that the nation should be moving towards. Dr. Mishra.
Thank you very much. At the outset, I would like to record my compliments for this very notable initiative. very meaningfully, very cogently, very credibly, and very timely undertaken with a very absolute degree of focus and concretization for the purposes of generating solutions to tackle this malady. Very rightly put in by the learned anchor. I am limiting myself, Chair, with reference to the academic component pertaining to this particular problem, because I have been a part of the regulatory mechanism of medical education for well over 3.5 decades. And as chairman of the Academic Council of Medical Council of India, I have tried to look at this problem dispassionately and even ventured into working out solutions. The burden of the problem absolutely is huge, gigantic, and very rightly put in by Dr. Ravi Vankadkar. It is a kaleidoscopic problem, multidimensional problem. No single approach will be in a position to give a pragmatic solution, because it is linked with social norms, it is linked with social psyche, it is linked with psychological dimension, it has got economic considerations, it has got professional contours, it has got legal dimensions, and it has got cultural moorings as well. I am limiting myself to the academic context of it. I am wanting to refer 1979 Belmont Committee report, which categorically brought out that medical profession and healthcare profession ought to have an educational model wherein humanities will be inbuilt into it. And therefore, it is imperative that humanities needs to be structured into the teaching learning program, whereby the learner is oriented to what is now classically in the educational parlance known as affective domain of the curriculum. You and me recall, as medical graduates, as medical postgraduates, we learned the affective or behavioral or attitudinal domain of the curriculum, not in terms of any structured manner. Speaking for the realization of this particular gap, I am referring to the World Federation Medical Education Guidelines of 1993 pertaining to the undergraduate medical education, where the globalization of medical education was mandated in terms of incorporation of absolutely attitudinal part, ethical part, behavioral part, humanistic part, altruistic part, the humanism part, and all this to be blended in what is classically called as desired levels of professionalism. One thing which I'm wanting to put across is, let us also look from the side of the healthcare providers. Has our curriculum and has our educational process incorporated within itself the required levels of incorporation of professional values, the required levels of altruistic values, the required levels of communicative efficacy, the required levels of ethical conduct and ethical commitment in terms of the principles which have been catalogued in various international declarations, including the Bioethical Declaration or Bioethics Declaration of 2005, read with 1948 Declaration of UNO. It is this gap preparing our young doctors. And learned chair, I would be referring to the document which has been readied by the General Medical Council UK, Preparing Young Doctors for Tomorrow, 2004 document, which categorically brings out we may not be in a position to alter the societal moorings and societal leanings, but should we therefore not equip our young doctors whom we are preparing for handling the healthcare delivery system with ease, elegance, and efficacy in a modern manner, that from their side we equip them with humanistic approach, communicative diligence, ethical conduct, professional ethos, altruism, and the wider contours of what we call as ideal, desired, cushioning, accommodative human behavior, which will be not only in a position to go in for rendering a healing touch, but also simultaneously working out what is called as a desired, expected, normal human behavior, which will be acceptable. It is in this context. Just 1 second, yes, only one. It is in this context we have ventured into incorporating attitude, ethical, and communication model, ATCOM model, inbuilt into the competency-based medical education curriculum across the country, of which I was the chairman for fathering it, and now it is included, structured into the curriculum from 2019 onward. And we believe that this academic intervention will be facilitating the purpose which I have delineated as a long-term solution. Thank you.
Dr. Mishra, thank you very much. It's important to note that years ago, decades ago, or rather centuries ago, we have a very apt Sanskrit saying which talks about this. It says, Anna Danam Param Danam, Vidya Danam Atah Param Mande Nakshanika Trupti Ya Vidya Jivacha. So I think it's very, very relevant to ensure that we not only incorporate these learnings into our doctors' curriculum, nurses' curriculum, but also actually make healthcare more empathetic, more humane. With that, I'd like to recognize and request Dr. Mukund Jagannathan. I believe there is a time constraint which we need to respect here for Dr. Jagannathan. Dr. Jagannathan is an old friend and colleague of mine. He's professor and head department of plastic surgery at the Lokmanya Tilak Hospital, Sion Hospital as it's popularly called in Mumbai. He's also the former president of the infamous/famous, if I may say, Maharashtra Association of Resident Doctors, which has always stood up very staunchly for against any sort of violence in Maharashtra against doctors and nurses. Dr. Jagannathan, over to you. I'd like you to please kindly give me your opinions, your views on what you have learned over the years and how we can improve. Over to you.
Very good morning to all the learned people here, and I want to thank the organizers for squeezing me into this slot. I've been associated with public hospitals since 1978, first as a student and then in varying degrees of seniority. I have seen a sea change in the whole concept. I would like to outline the changes that I have perceived over the years and the sad status today. A study, as Dr. Parag pointed out, showed that more than 80% of doctors have witnessed workplace-related violence. It may be verbal. There are documented cases of grievous body harm, damage to property. The famous Singhania Hospital incident is still fresh in our minds. The next unsurprising fact is the location and the timing. It is usually related to an ICU or emergency ward setting and late at night or very early morning. This is where a human being's defenses are at their lowest. By and large, death of the patient is the immediate precipitator of such sort of violence. Therefore, it involves people on emergency duty who are fairly junior, at least as far as doctors is concerned. Unfortunately, many patients perceive him or her as a non-entity. And the fact that he's qualified and trained to do the job doesn't really occur to them. Let's look at some root causes, some real and some perceived. Overcrowding, real. Overwork, real. Lack of resources, real. All real. Now, what is perceived by the patient and their relatives? No commitment, mostly untrue. No interest in the job, again, mostly untrue. Not communicating properly, as several people have brought out, this is partly true. We will come to this a little detail. Other thing, they feel that doctors are greedy and only interested in making money, which is what they have been portrayed by society. We have to blame the media for a great extent, for this, as well as some brushes with unscrupulous people. The biggest perception is that when a patient comes to a hospital and there is a problem with the patient, they believe that there must be a solution and the patient must be cured. Otherwise, it's the fault of the doctor or the institute. The other thing is that if a senior doctor were to give a statement, it would tend to be believed. Whereas if a junior doctor gives the same statement, he's likely to be beaten. I'll give you a personal example very briefly. I was in the Sion Hospital emergency, long case, and there were 2 or 3 simultaneous emergencies going on, and a corporator walks in with a patient with a bad forearm injury. And I told him that there's already 2 patients waiting. Your patient to be done after that. Very politely. This is a 7:30 evening. He said, I'm a corporator. I can, ruin your budget. I can spoil your budget for the hospital and all that. My patient has to be done first. I said, okay, just come with me. He said, where? I said, that patient is waiting from yesterday afternoon. Explain to him why his surgery is getting postponed. I can't explain because the postponement is not in my hand. You please explain to him, and if he agrees, we'll take your patient first. Naturally, he collapsed. The patient doesn't care. Now, despite all these reasons and so-called excuses from both sides, in my humble opinion, the reason why this thing is still perpetrated is because there is a lack of a serious deterrent. The laws have apparently been made stricter, but till date, it's still, I think, a little short of what we want. Many come with social workers, local politicos, and clouds and that kind of thing. I think gets suppressed. As someone said, the percentage of reporting is far, far greater than what is actually okay. Let's look at potential solutions, some within our control and some out of our control. Communication, as said by the previous speaker, is absolutely vital. Okay, and we have every year a new batch of research. We have special training sessions on proper communication, delivering bad news, declaring death, etc. All are very good, but in the heat of the moment, it falls on deaf ears. Even telling a relative there is no room in the ICU doesn't work. You get beaten up. Overcrowding, workload, staff shortage, vicious cycle. There's no answer to this. Lifestyle-related illnesses, accidents, and general illnesses have taken a quantum leap. Restricting entry works well in private institutions, very difficult in public institutions. We need to establish a hotline to the closest police station, a buzzer type, and this has to be treated like a potential riot situation with immediate rapid response. Short tracking of arrests, incarceration, and trials thereof. Doctors are a soft target. They have no union. The same thing if you try to assault a ward boy, you will have 40 people from the union will come. They will also hesitate twice before assaulting a ward boy. And therefore, I think we need to get some radical steps and make the deterrent very severe. I'm sure a lot of people will have a lot of other things to say. And I think I have basically summated what I have been feeling over the last 40 years in medical science. Thank you.
Thank you, Dr. Jagannath. With this, I'd like to recognize two senior functionaries of the Indian Medical Association, and I'm going to ask them turn by turn to speak. I had kept them on top of my priority list since they represent not only they represent me definitely. I am somebody who's a ardent IMA member. I'd like to recognize and welcome and ask Dr. Jailal to speak. Dr. J. Jailal is the National President of the Indian Medical Association. He's also Vice President, Commonwealth Medical Association. He's the National Coordinator, Indian Medical Association, UNESCO Bioethics Day. Dr. Jailal, thank you very much for being here. As we all understand, violence against doctors is not only restricted to physical violence and the gory scenes that come out. Violence, as per definition, encompasses verbal, emotional, sexual, psychological, physical, cyber intimidation, threats, abuse, bodily harm. Despite the fact that I've left clinical medicine many, many decades ago, I faced some sort of intimidation myself, though I work as the CEO of a hospital. Your views on how these things can be corrected, where the nation needs to go. Over to you, Dr. Jailal.
Thank you very much. First of all, I must congratulate for initiating this dialogue outside the purview of the Doctors Forum, because that is what we needed. Unless comprehensively we work, it will not be possible for us to achieve something very prudent and very useful for us. Yes, it is indeed a big challenge. It is like a pandemic. It is crossing across the globe. It is not only confined to India, and there every part of the country is facing this trying to attack the doctors. Probably, as you have rightly said, it is a soft target, and they are attacking the doctors. It is both physical and verbal abuse. The study which we conducted, which shows nearly 80% of the population of the doctors, whenever they are practicing, they have subjected to one or more times that's the violence they are happening. Many times not proceeded to the logical end because of the reason of various social factors and various issues which concern to that. Either they withdraw the complaints, or the law is not very strict enough to carry it forward, or they are playing intimidations in the society. So logical conclusion is very, very less. But we see only hardly 3-4 cases where there has been the punishment is been given. And with the innovative efforts of Indian Medical Association and many learned colleagues in the administration, we were able to create a law. It is a law of enforcing the safety of the doctors across the country. At on date today, 23 states in our country is having a law. But unfortunately, in this law, there is no criminal code of procedure is incorporated, and there is no particular section of the penal code is assigned to that exclusively. And there is no cognizance whose responsibility is also not much explained properly. And it is a law which is enacted in the state when the police officials who are coming outside from one state to other state, they are not very well acquainted with this law. So many times it is becoming difficult to incorporate or file the case on this law which is prevailing in 23 states. Even if after we pursue and able to put it, the pursuance of the law is not able to take in place. What we believe, we may be wrong, the Doctors Association, what we believe, if that can be converted into a central law, then it will affect and impact with the criminal code of procedure and IPC tagging, then it will have a more effect. There is a lot of resistance on that, and we raised, everybody accepted, the interministerial committee was constituted, that also accepted. But in the Home Ministry, they struck it down, saying that if for one section of the person, one profession, and if you create a law, exclusive law, then it will be a countermanding, and there is a lot of plethora of the request will be coming, so we will not be able to man. So at present, it is in the Home Ministry dustbin, this law which is proposed as a central law. And another objection was created, is the health is a state subject and we will not be able to make a central law. But there are many incidents like MTP Act, though health, it is related to health, it is a central act. But the government of India is creating an act for the MTP Act. If the MTP Act is allowed to be in the state, it would have been in a different way. Now only to today because it is a central act. So that the first demand which we are creating is the central law that we are trying our level best to do that. But again, our more concern is not to get someone to be punished on the law. That is not the
Thanks, sir.
priority of Indian Medical Association. And our what we absolutely believe, absolutely want, this should be prevented. Hospital is a more potential violent area because everyone in the hospital, unlike any industry, there will be machines will be more, persons will be less. Here, the product and output, everybody is human beings, and especially all these human beings will be in an abnormal mode. Doctor, nurses, patient, and the relatives, everybody will be in a tense mode. So there is bound to happen this violence and verbal abuse that need to be prevented. That is our priority. It is not our priority. Someone who has attacked the hospital should be punished. More than that, and if we can prevent, so that will be the area. That is what we are insisting on to be incorporated into the law. We have suggested various means. I'm sure during the course of time that you will have much discussion on that. Our priority and focus should be prevention than on the punishment, which is oriented at the end of the hospital violence.
Thank you, Dr. Jailal. Thank you very much for that. It's interesting that we have CISF protecting airports. We have other paramilitary forces protecting other institutions of national importance. Somehow, whenever we approach, whether it's private healthcare, you don't have very great support from the police. You are liable to be charged a per diem for each policeman that is stationed there. This money is subsequently added on at some stage to the patient's bill. That leads to further discomfort. And I think this Chakraview is something that we will have to learn to break. With that, I'd like to request another leading luminary who I have been seeing at the forefront of this fight for the last decade or more, probably. I'd like to invite and request Dr. T.N. Ravishankar, who is the current head of the Medical Legal Cell, Indian Medical Association National. Dr. Ravishankar, you have been grappling with this and we've been seeing you at the forefront of this problem. I have personally been interacting. I've been seeing how the IMA National has been working with this problem. I know for a fact that all IMAs have contributed significantly to this. What would you define as the 3 or 4 key significant factors that contribute to violence? And what are the actual things apart from the law? As Dr. Jailal said, how do you think we can actually prevent this from happening? And Dr. Pillai, I'd request you post Dr. Ravishankar's contribution to kindly sum up what has been said so far. Over to you, Dr. Ravishankar, sir.
Morning to all of you. And thank you for this wonderful opportunity. And I should add on to Dr. Our National President said that this is one institution that really cares for the medical community. And they have taken forward this issue with all the luminaries all over the world. Thank you very much, Institute of Medicine and Law, and particularly Advocate Mahendra Kumar Bajpai and our friend Ravindra Mangal. Thank you. I think everybody has enumerated what it is, and in fact, Jailal has gone in depth and trying to find out what the law should be changing and all. There are 2 things which why this is happening. It's a knee-jerk reaction of the public that they want the unexpected not to happen, the unexpected death, the expected outcome they want, and which is not able to be provided. The problem is there. The second issue is public's perception of the hospital and the doctors have changed a lot in the last 2 decades, and that is a major reason. It's a fault on us that we are not able to go and convince the public. We keep working for the welfare of the patient, and the commercial aspect is not under our control. There are times when the unexpected outcome was an expected one which a family has founded. But why the violence happens? The violence happens because there are people who does not want the commercial issue to come into it. They don't want the money, and they have parted the life of an individual. That is the final precipitating factor for a violence that can happen in a hospital. But I'll now quote the Dowry Act, which came into existence 3 decades ago. Before the Dowry Act was there, the number of dowry deaths that happened in the country was so high. When they had a perfect law to take things into the control, the number of dowry deaths have come down. And today, Medical Establishment Protection Act is there. But still, it is still not so effective like how our national president says, clause into it to make it much more stringent, and the public and the police is not still aware of the law that is existing. Whenever there is a violence in a hospital, you call the legal authorities, they call the law enforcing authority. The first issue is they take the side of the mass. The mass is there. When the mass is there, it doesn't mean it is always correct. When a strike is there, it is not. Do the strike is always perfect. They don't come into the existence of trying to support the hospital or support it. They don't want them to support. We want them to enforce the law that violence does not happen. And like you said, we need to have something where when there is a trickle of violence going to happen, I think the law enforcing authorities should come into the existence on the hospital so that things doesn't go out of control. When you have a strike going on, you have the law enforcing authority there. But then there is a problem in hospital. Hospital should be announced as a protected zone. Right now, there is a private bill in the parliament, Rajya Sabha. One of our own MPs from Tamil Nadu has presented it that hospital should be made as a protected zone. When it is made a protected zone, like what you said, like in an airport, you have all the facilities to take care of it. And the last one, which I also like to say, there should be a redressal mechanism. Why are these people hitting out? One aspect is the loss, one aspect is the commercial aspect. The next one is, and even if they want to go for a redressal mechanism, it takes years together to get the redressal mechanism. And the redressal mechanism is not the one. Whenever there is a violence, and if you find a lawyer coming and there into the masses, they see to that we part the money before they go out of the hospital. Because these lawyers know that how long it will take for a case to settle in the court, even if it is going to be in the district or in the state forum. So the redressal mechanism has not been of adequate satisfaction to the public, and the perception of the public about the hospital and the doctor's service should change a lot. I was one person instrumental in our country, the second state in our Tamil Nadu was the second state to enact a Hospital Establishment Protection Act. I know how difficult it was to convince the government when it is going to be the second state, how much more it will be difficult. We could do it only reaching the chief minister of the state directly through the medical community. This medical community, he will be able to do, and I think our national president has done the best in the last 1 year to do the safeguard. And if all the allied people could put together, trying to make a change in the law that is being enforced, as well as everybody will talk about how we have to communicate. We will do it. We will do it. And the redressal mechanism and the defensive mechanism should be made much better for the hospitals to have a better and easy practice. Thank you for the opportunity.
Thank you very much. Thank you very much. Dr. Ravi Shankar, not only was that very crisp and fruitful, I think there are some clear suggestions which we will be taking in and putting it down in the white paper. Dr. Pillai, over to you, sir, for crisping up what we've said so far.
Thank you, Dr. Parag. And really wonderful discussion, all panelists, solution-oriented, focused, and driven by a lot of experience and insights. So what came up so far? Educational reforms. Educational reforms that focus on building social skills and empathy in medical students, future doctors. So glad to understand the initiatives that are already underway in that regard. At least one speaker mentioned that the Consumer Protection Act, what is the real situation? Are we in? Are we out? And definitely, is this a problem and what do we do about it? Managing expectations of patients, especially when there is a death or an adverse event. One speaker mentioned, and very rightly so, that most problems are rooted in poor health system management, which is exactly where I come in from. That violence happens because, or a death happens because an essential drug was not available on time, or if violence happens because there is not enough critical beds. This is not a legal problem. This is not a problem that the courts can fix. This is a problem that then rose back to the fundamentals of our health system management, of a poor investment in public health infrastructure, for example. Hotlines to police stations were mentioned. Central laws were mentioned by almost all speakers. But at the same time, other speakers have highlighted that police automatically tends to side with the mob. There is a certain sense of apathy. And this may be because the profession has a PR problem. The profession has not been able to take the public into confidence, have the public on board that we have the best interests of the public at heart. And this is where I also come in when I say that strikes are probably not helping this narrative, because strikes is a binary of doctors versus the public. And I'm also like I'm very happy to hear that I'm very happily stand corrected that convictions have been ongoing. My impression has been that whatever legal remedies are available have been under the regular sections of IPC on grievous hurt, for example, and not specifically the Clinical Establishment Protection Acts. My understanding, I have not been able to find convictions under the new laws that have been passed in response to doctor strikes. And if this is the case, I believe it is also because the laws have been passed under duress by the threat of strikes without buy-in from the larger society and political class. So I would invite us to also reflect on, and I'm so happy that we have new speakers coming in with deep insights of policing, for example. There is a practice called dual FIRs. So when there is a complaint, that when a doctor has to make a complaint and the police station is so understaffed, there is a complaint taken from the police side on from the side of the patient on the doctor, and from the side of the doctor on the patient or the patient's representatives, whoever it is, which kind of then puts the doctor, even though the doctor is a survivor or the clinical establishment is a survivor, at a certain disadvantage. I think this has been summarized till far, and I would invite the next speakers to reflect on how we may be able to effectively coordinate a better PR response, work with the policing systems, and also work towards strengthening the health systems. Thank you so much.
Thank you very much, Dr. Pillai. I'm going to keep this crisp. The next set of speakers, we will be speaking with Dr. Siddharth Satpathy, Dr. Gurveer Singh, Dr. Pramod Rajput, and also with get an insight into the psychology of patient violence. International accreditation today also talks about second victim and handling of second victims. We'll also discuss that. And subsequently, we'll request Dr. Pillai to come back and summarize. At the next part, we will be inviting Dr. Goswami, Dr. Sunil Kumar, and Dr. Rana, because that's kind of a myriad of professionals who's going to shed different colors of light on the problem that, as we stand. So before I move ahead, I'd like to invite Dr. Siddharth Satpathy. Dr. Siddharth Satpathy is a professor and head Department of Hospital Administration, All India Institute of Medical Sciences. Dr. Satpathy, all of us know that in India, we've had this problem for decades. But we also know that the pandemic has also brought about a much larger, keener focus on this. And, it's kind of brought about the socio-cultural as well as the ethico-moral dimensions of what we're working on. How do hospital administration teachers see this? How do administrators see this and handle this? Over to you, sir.
Thank you. Thank you, Dr. Parag. I take this opportunity to thank Ravindra Mangalji for inviting me. I'll just share a little bit of our experience at the All India Institute of Medical Sciences. I'm sure with the pandemic, most of the viewers are aware about the All India Institute of Medical Sciences. Now, to me, as a hospital administrator, this is a very complex issue. There is no doubt about that. The earlier speakers have said. Now, how I see it from a hospital administrator's view is that this is basically on the backdrop of a demand-supply mismatch with very high emotional quotients, being played out. Mainly, it happens at the All India Institute in the emergency. Now, we take in somewhere around 450 to 500 patients who report to the emergency, and not, all of them, require admissions. So if about 100 of them or 80 to 100 patients require admission, maybe about 30 or 35 get in. The others are referred to other hospitals, and that becomes the flashpoint at the All India Institute of Medical Sciences. Now, being a researcher in hospital administration, I can say that it would have external causes and internal causes. Internal causes would be under our control, but the external causes wouldn't be in our control. External causes include the context, the political milieu, the legislations, the way society sees doctors, and many of the things which the other speakers have said. I will focus on the internal issues that we have, done and that we face. Now, one of the other speakers said about medical education and the EdCom module, which has been reintroduced recently. Somewhere I feel that the focus of the medicine has moved more towards machine and has left the humanistic aspects while the MBBS, curriculum. So probably, this is a step in the right direction. It will start yielding results maybe after a couple of, years, and when people become more and more, engaged with this sort of a thing. Secondly, we have to look at access control from the point of view of emergency. In most of the public hospitals, we have a system where the junior residents, non-academic, or the younger junior residents are generally put on more, night duties. So somewhere we need to also look at and retrospectively think as to how we can have a system where the senior doctors can be immediately called as and when a flashpoint occurs. And I'm talking again in the context of emergency. So some amount of perimeter control and access control for the hospital authorities is a mandatory thing that we need to probably do. Display of the information is something that we have done. One wall as you enter the AIIMS main emergency, there is a notice put up by the Delhi police. Fortunately, we have a small, police cell, which is, very near to our emergency. It's about a 3 minutes, run from there. So the number of instances in the emergency at AIIMS have become lesser because of stricter, perimeter control. We also, have a system of institutional FIRs being filed. That means when a resident is complaining to the duty officer, the department has a, duty officer in the control room, which runs 24/7. And, the security officer is then told to investigate and then lodge the FIR. Thereafter, there is a mechanism that the standing legal councils, follow it up in the court of law, and then that's how we go forward. So I think I am done with the AIIMS specific things that we try to do. But yes, it is not replicable in other healthcare institutions, especially the smaller ones. For them, it will be a little different. Yeah.
They were telling कि तू तो रोज यहाँ.
Well, thank you very much. If I could request mics to be on mute. We are hearing a little bit of crosstalk. Probably your spouses, Sunday morning is a busy time at home. Thank you very much. Dr. Satpathy, I think that was very crisp. Thank you very much for shaving off 20 seconds and still being extremely meaningful in the contribution that you've had. Nothing less expected from somebody who's working as head of hospital administration at the All India Institute. Thank you very much. I now request and move on a little bit. As you can see, we've kind of been focusing and getting all the senior professionals, the IMA professionals up front. We've now spoken to two people from public health. That's Dr. Jagannathan and Dr. Satpathy. I'd now like to move on a little bit and I'd probably take a minute here and explain to you what happens when even if you have perimeters. I probably represent private healthcare, and maybe if I may count it on as a panelist, I'd just like to tell you what happens when you have a dead body of a corporator being brought in. We try to resuscitate. We have perimeters, we have police, you've got bouncers, you've got security, and then you've got a mob of 80 people who are supported by another 2 corporators of opposing party who comes in and tells you that there's no way we are going to subject this body to a post-mortem, though it's the law that's been framed by them, by monies that have been paid by us. And then you're told that this is, we are not going to allow it and you do what you want. And unfortunately, they belong to the ruling party. And whatever happens, the body is taken away. Now, it's just spitting in your face as an administrator, goes against all rules and regulations that you do. So somewhere the question will arise, who's going to monitor the monitors? So with that, I'd like to also understand what's the private and corporate healthcare's take on this. May I request a very, very senior professional, somebody whom we know for quite long, Dr. Gurbir Singh, Professor Emeritus at the Chitkara School of Health Sciences, Chitkara University, Punjab, also the former head of North India at Fortis Healthcare. Fortis Healthcare, Wokhart Healthcare, Care Hospitals, all private healthcare is always pulled up for multiple things, whether it's overbilling, whether it's professions getting beaten up, medical legal cases. We always bear the brunt of it, but we know that, Dr. Gurbir sir. Dr. Gurbir sir, your opinion, what is private healthcare not done, or rather what has it done correctly? And do you see similar number of cases of violence against doctors, nurses, healthcare professionals? Let's reiterate and redefine that we're not only talking about doctors here, we're talking about all healthcare workers. Sir, where do you see this problem in private healthcare? What has been your response, and how have you dealt with it in the past as head of a leading chain in India?
Okay, Thank you very much, Parag. First and foremost, having heard all the speakers preceding me, most of them have put their finger on to social links, cultural links, and also bordered around the political scenario. Now, if I were to, as a erstwhile pathologist, that if I was to go somewhere, now I would go as per what is the baseline which leads to violence. First of all, it would be commerce without morality, science without humanity, knowledge without character, politics without principles, and two of the last two, which I'm going to tell you, are the ones which are relevant to the north here, where people had the opportunity to sell off land and suddenly from bicycles got into Mercedes-Benz and such like the neo-rich. It is wealth without work and also pleasure without conscience. Now, these are the few fundamental things which bring about the violence. Now, you said how did the corporate world protect itself to some extent? All right. Now, two of the speakers, when they spoke, one alluded to the recent pandemic, and we are still with it, and it's here to stay. We know that. While the civic participation in public health is critical to all goals of health, there was an inversion which we saw in the second wave. Public health being surrendered to the hands of the public without mediation of, say, the healthcare provider. Hence, the sole and moral responsibility burden fell on the patients and attendants. And this was a potential condition for resentment and discontent. Now, the other thing which Dr. Pillai in his presentation showed one lady with a small child in her arms. For the aggrieved patient, the space of the hospital and the figure of the doctor, it becomes embodied, incarnates into the state invisible treachery. While the dead body of the patient becomes evidence of the moral failure of the doctor, the medical system, and the public health system. Now, going back to another root cause, what are the 5 stages of grief? The second one is anger. All right. Now, you asked, and I also went through, fortunate to go through that article which you quoted about Ghosh. I also went through that, and what we in the corporate and the private hospitals, we have got very powerful, very elder, very trained people as grief counselors. And when we see that this is going to be a precipitous downhill course for somebody, we involve the grief counselors who continue to, somehow peter down the what is going to happen.
Fine, sir.
Okay.
So you can complete your sentence, sir, please.
Yeah. So anyone who does come, and like what you mentioned, was they feel that, and everyone mentioned about communication, empathy, and such like words. Yes, multidisciplinary, councils meeting, team meetings were done for all such patients. And of course, yes, we also try to make it into a protected zone, a vital asset, vital area, and closer links with the police. Isolate the people from the hospital. And when you see rowdy people, and particularly during the election times, you'll find a local politician who gets whiff of something and brings about 200 people. Now that is a potential time bomb. Thank you very much, Prag.
Thank you very much, sir. That was really crisp. And I'd just like to also enunciate the principle of primum non nocere. Essentially, healthcare institutions do put up systems and processes to do no harm. At the same time, I think all of us need to realize that at some stage there is a system breakdown. When we study quality, Dr. Rana will probably second me on this. When we study quality, we always say that all mistakes belong to the system and the system belongs to management. So in some way, we as a nation are the management of this crisis. In some ways, the police is a major supporter of whatever goes on, the good, the bad, the ugly, and they are there to police, and that's the role which we expect them to do. But before we move on to that, I'd like to also invite another proponent of, if I may say, a representative of private healthcare, Dr. Pramod Rajput. Dr. Rajput is a member of the Leaders Excellence at Harvard Square. He is currently the Senior Vice President and Vertical Head in Cadila Pharmaceuticals Limited. Dr. Rajput, your views on what are the maladies that are currently afflicting us in this area, and how do you think we can actually improve? What are the few concrete steps that we should be looking at taking, sir? Over to you.
Thank you, Parag sir, and very good morning to all the eminent personalities here. And thank you on the onset. I thanks Ravindra sir for giving me this opportunity. Right. So I was listening very clearly and quietly because from last 40 years, from last 4 decades, I am being associated from the hospital to the doctors, to the medical industry, to the nurses and all, because in a different segment, either it is a corporate hospital or it is a private hospital, or either it is a government hospital, because we keep on visiting and we keep on seeing the different behavior of the patient, the doctors, and also the paramedical staff. So, right. So what are the 3 things are there? Since I have 3 minutes of time, so I'll talk on the 3 part. One is that why this patient becomes so violent, because when it comes to the hospital, he thinks that he's coming to the heaven to meet a God, that why this God has been converted to a devil, right? And why he becomes that he sees that he has come to the hell part. So this is point number 1. This is the genesis of the entire problem, right? Then the second thing is that from the doctor's side, you all agree that your doctors having lot of work. I have personally seen in the government medical colleges and in some of the private hospitals, the seniors are sometimes not available. And this poor guy, right, who is there along with 2 or 3 nurses, he or she is handling a multiple group of the patient. So, and what the Ravi sir has said, that from 9th standard, that the parents, they start putting a pressure on the child to become a doctor. So in the bargain, they miss that emotional quotient part. There is a humanity, and humanity has been missed. And when the person becomes a doctor, that emotional intelligence part is missing somewhere. And that is the reason whenever there is a stress is there, then they start reacting it. And whenever there is a reaction, you will find there is a negative approaches there. So in that bargain, you have to have a proper response, because response is always positive, reaction is always negative. Second thing, sir, I like to highlight here that whenever we have spoken the corporate hospital, like there should be a emotional agility or emotional resilient classes to be there, given there, which, believe you me, they have taken some of the hospital, they have taken it in a positive way. Some of the hospital, they said, no, we are well equipped. So that is the thing which has to be cleared, because it is a continuous process. You are getting the healthcare staff. I'm not talking about the doctors now, the nurses and all. They are coming from the different background. They would have done the course, but they are not aware about the skills part. And that is the reason when they speak negative part in front of the patient, they speak something negative about the doctor, that this doctor is not clear. This patient, when they are standing with the attendant of the patient, they said that the patient number 32, all the attendants are very irritating. See, these types of the negative words should not be spoken. And I have not seen that such type of inculcation has to be given, because this is going to take care for the further part. This is the second point which has to be taken. Third point, sir, I like to highlight, because today, first is prevention is better than cure. As a doctor, we always say, right? So how we can prevent it? The thing is, I have not seen that whenever the board has to be there, like during this pandemic time, for 20 rupees mask, if you are not wearing, 1,000 rupees penalty is there. But if somebody is doing bad thing, the penalty is 2,000 to 5,000 rupees. Today, a cobbler can come and he will pay to 2,000 rupees and he can get out from the things. Today, the judiciary is not doing it. So why can't we put this request that we can increase the penalty from 2,000 to 50,000 on 1 lakh rupees? And it should be mentioned clearly on the board, on the emergency, every ward, that if you are going to do injustice or if you are mishandling the doctors or the things, you will be penalized about it. Second thing, sir, I like to highlight here, which I was listening very carefully, like we have the Aadhaar card system, right? So somebody is mismanaging the thing. There should be one time warning, second time warning, third time it should be given in the passport even that yes, this person is a rowdy person. So it will be a blacklisted part, which is very, very important. Third
Dr.
point,
Rajput. Yeah.
right. So third last is that media has to be taken, because media should not be highlighting about the negative part of it, sir. That is very, very important. So this is the three things which I like to highlight here. More, I will discuss more. Thank you, sir.
Thank you very much. Thank you very much. I think that was quite crisp. I'd just like to now understand, and then the next group of people whom we'd like to speak to is going to be Professor Dr. Russell D'Souza, Shankar Das, and Shauli Chakravarti. I'd like to start to sort of subset this third section, if I may. So we've heard the national authorities representing the doctors. We moved on and we actually spoke to a few doctors representing both public as well as private healthcare. I'd now like to understand the second party in this entire transaction, the people, what the patients, their relatives. How exactly is it that they perceive healthcare? What is it in them that triggers this particular emotional violence streak, whether it is just abuses or whether it's actual physical contact in a very harmful way to healthcare workers? I'd like to first start, and thank you very much for joining us from across the seas. Dr. Professor Russell D'Souza, Dean and Professor, Organizational Psychological Medicine, International Institute of Organizational Psychological Medicine at Melbourne, Australia, Doncaster, USA, and Florida, USA. Also the Chair and Head Asia Pacific Division, International Chair in Bioethics. Professor D'Souza, your views on what actually triggers this? What is it that goes wrong? What do healthcare workers need to learn on the psychological front to ensure that this sort of behavior is not triggered? Over to you, sir.
Thank you, Dr. Prag, and my congratulations to the Institute of Medicine and Law for this important area, picking up this issue, and thanks to Dr. Ravi Venkatka, who had introduced me or invited me here. Look, all of you have given some wonderful areas, and as you all agree, this is a complex, multi-factorial area that is impacting. We have institutional factors, we have socio-environmental factors, we do have healthcare professionals, and that's where education and so forth. And then, of course, the facility, the healthcare facility factors, and the patient and their relative factors. All these factors are there, and every one of them have got areas that can be improved and worked on. Now, I would want to talk about an area that I have been involved in. I'm a professor of psychological medicine. And organizational psychological medicine is the branch of psychological medicine that works the workforce, that actually looks at the workforce and how do we enhance the potential of the workforce. Now, very important here is what I think we see from what the other Dr. Ravi has talked about, emotional intelligence, Dr. Ved has spoken about educational part. And one of the things that two things that I identified. I trained in India and then came out. I've been away for 40 years and now back doing a lot of work in India. And one of the things I would see the difference from what was there and what is the patients have learned, have now become more aware of what they are entitled to, what they expected, what they can expect, which I think is something good. And at the same time, they have access to courts and so forth. The other important factor that I realized was the lack of training, which has been put forward here. that for the doctors, well, there's also lacunae in emotional intelligence due to the force, as you all mentioned, students being groomed to become doctors without having only following the cognitive intelligence or IQ, forgetting the importance of EQ or emotional intelligence, because medicine is a social science. It is a social science, right? And so I see the difference being, while every country has got this problem, there are some specific problems to what we see here. And of course, the lack of absence of humanities, because humanities in the West in the last 20 years has become an important part where we need to understand the expression, the feelings of the patient. We were not just biological, and that's every teaching hospital or college has got a department of medical humanities now. Now, the lack of teaching of ethics itself. And I think we were very fortunate that in 2000, we started a program. I came to India with the UNESCO chair in 2013. But in 2015, we launched with the then Professor Dr. Jayashree Mehta, the Medical Council chair. And I think Ravi was with me there at that meeting in Nasik. Very importantly, in Maharashtra was the place we launched the bringing in of the curriculum into the undergraduate training. Of course, it came in later, and Dr. Veddes, who's also part of my team, had mentioned about 19, and it's come forward. But very importantly, at that same time, we realized that we needed doctors also to be trained, and it was, I think, Ravi and the other IMA joined with the UNESCO chair in bringing training on this very important area for practicing doctors. And the third component has been bringing into the National Board of Examinations. They have joined with the UNESCO chair, and we have brought in a curriculum even for the postgraduate training. Now, why is this important?
Thanks, sir.
Yeah, because we want to get better communication. We got to get an understanding of not just the four principles, but the broader concept of the Universal Declaration on Bioethics and Human Rights, which brings in a lot more into vulnerability and access and so forth. So these are important. While I acknowledge there's a large number of areas, I focused on this important area that has now come, and as you rightly said, Dr. Prag, we will see the benefits of this in the next decade or so when the new undergraduate and postgraduates come out much more trained in this area. Thank you very much.
Thank you so much, Professor. Really appreciate that crisp communication. I now request Ms. Shauli Chakravarti. Shauli works with Swasti Health Catalyst, which is a United States AID and UN partner non-profit initiative, has more than 20 years of experience in development sector, specifically working on gender, public health, workforce, well-being, and environment. Shauli, have we deteriorated so much that we really need to beat up our doctors and nurses? What is the society coming to? What's your take on this, Shauli?
Thank you, Parag. First of all, I think I should just thank you for having me here to speak on the topic of violence against healthcare providers. So my dear esteemed panelist and convener, just to tell you that I represent the sector which encompasses public health, humanitarian development sector together. I also lead the well-being for workforce practice area, which probably many may not have heard of. And healthcare providers are one of them. I know probably it will be very provocative. It may sound like that, but I would like to start with some fundamentals. I think I've been hearing my esteemed panelists talking about violence at different levels, but also violence. One is, I think, two subsets of it: violence against healthcare providers and violence in healthcare spaces. I think these are two fundamentals that I would like to begin with. And also, I think what is very important is that who encompasses healthcare providers before I go to consumers and community. Because for us, doctors, nurses, paramedics, even the lab technician, the frontline health workers, everybody matters, right? So who is entitled for justice and what are the relevant support? So I in that space, I would just like to kind of bring, before I move to solutions or, that the attitudes or expectations that consumers have, probably. What we do, is it enough? Because we keep saying that, we understand the underlying causes, but do we really focus on the vulnerabilities? Vulnerabilities from both the, healthcare providers and the consumers, maybe, here, or the communities. We have seen different types of violences taking place during the pandemic times, and it has been very alarming for all of us. But at the same time, I would like to kind of emphasize on the fact that how inclusive, empathetic, and gender sensitive are those who drive the system, policies, and decisions, who ensure inclusive practices, healthcare practices. And then one of the major facts, because I come from that background also, is that majority of healthcare providers, when we talk about, we also see that they're women, and there are, of course, other sexual and gender minorities. So I would like to also invite focus on this issue that, when we talk about vulnerabilities, do we take necessary action, and do we keep them in mind when we are talking about that? So, from that point of view, I would like to also emphasize on the fact that, gender equity and social inclusion is equally important when we talk about the rights of the healthcare providers as well as the others who receive the healthcare, right? And most of the time, violence, when we see, are a direct result of deep-rooted norms and practices, and we tend to get into more band-aid solutions, knee-jerk reactions, rather than looking at, systematically, addressing prevention, rather than just redressal. I think that is something that I would like to invite again to focus on, that when we are talking about solutions, that let's look at not a one-time solution, a continuum of it. It has to be addressing social and other factors, but also, most importantly, the root causes. And I had a lot of learnings from what I already heard from all of you here. I would like to focus on, that's why, early prevention as a key approach, and also looking at institutional capacities and system strengthening as some of the solutions. And also, solutions may not be complex in nature, but then we have to look at it from the ecosystem of healthcare providers. And I think that is something that we tend to miss out, that we need. And I know that today we have brought in a lot of people who are from different sectors, but it will be good to hear more voices of victims and survivors as well when we talk about solutions, and also investing in efficient and inclusive gender solutions. And lastly, I'd just say that, even a simple solution may act as a deterrent. So let's really focus on this. And I'll just close on, and I know there's a time is an issue, so I'm just closing on by saying that, are the solutions that we have discussed till now enough? Are we just doing band-aid solutions, or we are actually looking at systemic solutions? Can we look at early prevention? And are we incentivizing violence by not looking at the whole ecosystem? Thank you so much.
Thank you very much, Shauli. I think that was represented very well. I do believe, and I always believe this, that all mistakes belong to the system and the system belongs to management. We are the managers of young India, and we need to correct the systemic problems that there are. At the end of it, we must remember that behind all the violence is a failed system. And if we don't correct the system, while we may have, as you rightly said, band-aid solutions, we're not really going to come about. I think what's very important is that violence at some stage should not get structured, and then that will be the bane of healthcare. Thank you very much, Shauli. I'd like to introduce and welcome Dr. Shankar Das. Dr. Das, Professor Das works as the Dean of the famous Tata Institute of Social Sciences, the School of Health System Studies. Dr. Das, your view, society, healthcare, two extremely complex and intricately woven kind of organizations, if I may put it so. And they are organizations, they have clear class distinction, hierarchical distinctions. How do you think we would be able to address the issue of quote-unquote violence against quote-unquote all healthcare workers, organized, unorganized, private, corporate, public? How do you think we can address this, Professor Das? Over to you, sir.
Thank you so much, and good morning to everybody. So many congratulations to the Institute of Medicine and Law, and then thanks for this opportunity, particularly Dr. Ravindra Mangal and Dr. Eli, Dr. Redvani. Thanks a lot, and esteemed and most learned, presenters. Thank you so much. With this small, very kind of you that you have introduced to me. But yes, I was once upon a time a victim of a violence in one of the best, mental health facility. And it was a traumatic experience, but I remember that day. But anyway, but still the violence is the ultimate truth, and this is growing globally. And the most critical discourse all over the world. And definitely, as we have discussed so far, there is no easy solution on the horizon still. But anyway, some people say it. One hospital, two emotions, a new life, a life gone. But that is an anonymous small quote came. But one life came, was born, one life gone. What happens in between is a great and just way of putting this anonymous quote. I add this quote should be a many healed is not included. Hospital is a place where it is such a congenial atmosphere for people to come, get treated, get better, and it has a greater value for the development of any nation. But ultimately, a hospital is a very small or the microsystem in a macro perspective. Now, if it is so, it really has a greater implication in terms of various psychosocial implication, economic implication, in terms of maintaining a harmony, equilibrium in terms of its function. I believe that we were absolutely taken aback when the last second wave, when we realized that the government and the state response towards this COVID was so abysmal. And that is the reason you have seen from all the state, the violence was extremely brutal, and sometimes even the vandalizing the hospital facilities. These became extremely critical for healthcare system. I absolutely agree with all the speakers. The main issue is the reaction of anger. Many of you have very rightly said the grief reaction. It was not coached. Originally, the work was by the Elizabeth Ross Kubler. Is a Death and Dying, one of the landmark book where the Elizabeth has very rightly said the anger is a reaction to death. And there is a response is nothing but displacement of anger by their near and dear ones. Why does it happen in emergency services or in a critical care services when you know that eminent, outcome may be the death? But is there hospitals are ready or tackling the patients who are going to or anticipating those kind of eventual or any kind of a eventual information? Now, that is the reason what we have done so far in the hospital is a greater amount of egocentrism without understanding the ethnocentrism, where we need to take the community perspective in place, where we need to have two very important cadres of the people, where most of the Western countries are very successfully doing, but it's still healthcare, violence has not come down. But in India, we could do a greater justice in terms of filling up two very important professionals. One is the clinical psychologist, and next is a professional social worker. They can liaise in this kind of a very, very uncertain, very, very emergency situation, which is almost like an air of emergency during the time. There is some kind of liaising work has to be done between the healthcare provider and the, and the clinicians or the, the patients as community. And that is the ultimate truth. We need to really look deeper and really do a lot of work in this kind of a thing. And I just one small, thing which I wanted to tell you to all of you is that when somebody very rightly said, Dr. Misra, is that we need to really talk about three different professional dimensions of training. One is a 3-8 approach. One is a head, another is a heart, another is also the hand. We have huge amount of technical expertise, that is the mind building the head building. What happens to heart, the values, the communication, the whole philosophy of life, being a good human being? And the last is in the hand is the skill. And that is should be the part of our curriculum in all. And Tata Institute of Social Sciences, we do this kind of work. Thank you so much.
Thank you. Thank you very much, Dr. Das. And I'd now like to invite one more important participant to this entire discussion, or rather an entire, what should I say, one more key link to this entire thing whom we always speak about. I'd like to invite Dr. Goswami, who is an IPS officer. He's an academician. He is also the chief of the anti-terror squad of Uttar Pradesh. He's also a former director of the Central Bureau of Investigation Academy. Dr. Goswami, sir, we've some part of this you may have missed as you joined a little late. There was some conversation about police occasionally, turning tables and trying to defer or deter people from signing FARs. There has been quite an ambiguous role of police across states, as we can see. My question to you is, what is the legal stand that the police has in majority of these 23 states where this act has been enacted? Your position, please, sir, as the police, sir. Over to you, Dr. Goswami, sir.
Yeah, good morning to everyone. It's indeed great pleasure to associate. I could hear you all talking very important and vital topic, the protection of the healthcare system, various segments, doctors and other paramedic staff. As a police officer, I have also seen such scenario. But before entering into this question, let me just, please give me just 2-3 minutes so that I can just get back to the, although majority of things which I want to tell have already been covered. But as Dr. Rajput had mentioned very clearly, the social background, actually any problem, be it a crime or any other problem, has some social, economic and sometimes political implications. So if we see the development of the modern medical facility and compare not more than some 20, 25 or 30 years back, when probably we at the age of around 45 to 50, there are senior doctors and senior persons also. But in last 2 to 3 decades, there is a sea change. Initially, doctors were considered in a different paradigm, although till date, you are considered next to God. But over the period of time, the scenario had changed. Earlier, there was patient-doctor relation directly. But nowadays, because of economic compulsions, nowadays, the medical facility has become like a business. Earlier, there were clinics. Now we have very high-profile hospitals. There is hardly interaction of doctors. We do not know who the doctor will treat us. Earlier, we were knowing that to whom we are going. So this kind of interpersonal relationship has changed. And that has definitely have bearing on this whole system. Secondly, it was rightly said that intolerance. In our general mindset, intolerance is missing. That is another point, whether it is society or doctors, police or whatsoever. So that kind of, there are so many reasons behind this. As I already told about the financial part, the medical system has entered into corporate culture. So if we are borrowing a culture, we have to borrow it in a holistic manner. We are considering about 30-40 year back scenario, but this is the modern era. So that is one point actually I want to tell. Now let me come to the security regime, the law and security regime. So if there is any violence, be it with a doctor, be it with the police is also facing sometime the scenario like doctors are facing because of various reasons. Police is not immune to such type of, you might have seen a lot of police station burning, vehicles burning and whatnot. So the security regime is a big challenge. Of course, we have plenty laws in hand. And if we implement them properly, I don't think that there is any need of any separate law per se. Although if it is being designed, I have nothing adverse to it. But at present also, we have sufficient legal tools to handle it. But observation normally is that when there is immediate scuffle or some kind of violence, then doctors or any victim, whosoever, they are very active. But over the period of time, in most of the cases, there are compromise. So my request here is that you may please think over that how the investigation should be expedited, and then if the case gets charge sheeted, how it should be speedy trial, so that the deterrent people, they should get punishment. Otherwise, mere lodging FIR or just lodging them behind bar for say few days, few months or so, it will not serve the purpose. So deterrence is very important. And you may request the system that our cases whatsoever of this kind, they should be put for fast track courts. That may be another point. Then there should be a proper, because most of the time, these are not very different type of scenario. There should be a protocol for such type of things, how to collect evidence. So that can also be a ready-made solution. If an effort is made by some specialist and a proper protocol is being devised, it will help the investigators, whether they are in Karnataka, maybe Uttar Pradesh, because IPC and other laws are similar.
Time, sir. Request you to wind up. You can take a minute more and wind up, sir.
Okay, I will definitely wind up.
Yeah, thank you.
The last thing, although this topic is very wide, my only request is that you always think that the negligence at the part of doctor is also be taken very seriously. Law is not very clear. Law is bleak, rather I must say. And there are large number of cases where people feel that there was negligence, but we could not get justice. So I think you people must also think that if there are cases of such negligence, you must come forward either to compensate by your own, because if a doctor goes, if a patient goes for dealing the negligence at the part of doctor, they hardly get any, some kind of solace or some kind of satisfaction out of that exercise. So that is also very important. One last point I want to say, that in most of the doctors, in most of the hospitals, there are police posts. So if there is a better coordination, I think things can be taken in that way. And of course, education and other things which have already been taught. I think it is a big topic.
Dr. Goswami, you're on mute. Unfortunately, we can't hear the last few sentences.
Okay.
Yes, thank you.
So I just want to say that if a good coordination between the police, local police and the hospitals, I think many things can be attended. But yes, this is a very important topic and it should be handled with due care and attention. Thank you very much for giving me opportunity. Any other question if you have, please?
Thank you, Dr. Goswami. Just to add to what you're saying, it's probably, it's not a rebuttal, but it's just something to add to what you're saying. If the government would have done what it had to do by putting in 3 Tesla digital MRIs and the infrastructure required for Indian healthcare today, I don't think corporate would have pumped in so much money. Yes, it has become something of a business because there are bank loans to be repaid, salaries to be paid, and one other thing that probably I might want to add for the policymakers to introspect and look at, introspect and look at the staffing patterns across healthcare today. Some of the outcomes that are noted across healthcare also have to do with the levels of staffing and the skill set improvement or the competence improvement over the years that we are supposed to look at. I've got a very interesting speaker now, and as we keep saying, we're talking about systems and processes. One thing that we have been reading in international accreditation is the treatment or the focus on the second victim, a victim who incidentally suffers getting beaten up because of some blame lying elsewhere. National accreditation is still somewhat silent on that. And I have a very eminent leading personality who's been working with accreditation from the laboratory to hospitals and healthcare providers, now even down to dialysis centers and home healthcare and so on and so forth. A very old friend, my teacher and guru, Dr. Bhupender Kumar Rana, who was former director and CEO in charge of the National Accreditation Board for Hospitals and Healthcare Providers, currently functioning as CEO of Quality and Accreditation Institute of India, who is also board member of the International Society of Quality in Healthcare. Dr. Rana, my question to you is, what needs to change in the Indian context of accreditation vis-a-vis violence and prevention of violence? I believe that accreditation has introduced a specific standard on better communication. And second and most important, with your experience of interacting with International Society of Healthcare Quality, what do you think could be the learnings that India could replicate from dealing with violence in other countries? Over to you, Dr. Rana.
Thank you very much, Parag. The wonderful. Thank you, Dr. Ravindra Mangalji, for having me here. And thanks, Parag, putting me into the order now. I could get the advantage of hearing the too much of education, learning from the dignitaries available here at the moment. So thank you so much for all that. I think this is a very complex topic, and I'm not the one who is repeating it. Everyone before me said, and we keep saying it in future as well. I see it's like the first statement I would like to say: the violence in any form in healthcare facility is not acceptable. Just not acceptable. Now we need to go down that what are the reasons behind that, and there are several reasons. Again, being a complex ecosystem in healthcare is not one factor which is responsible. What I do see, as in my last several years of experience with healthcare facilities and workers and around the world as well, that I see that two catalysts basically. First is the primary catalyst, which is an immediate patient relative or attendant who is there with the patient and takes the things which comes forward as the patient is being treated. And so that's first catalyst. And second catalyst is not the patient attendant, or it is someone else. It may be foreign relative, it may be the community, it may be a neighbor, it may be anyone around which actually participate in the violence later on. But the first catalyst actually is important catalyst, because from there the second catalyst get activated, right? And then things started getting wrong. So how to stop the catalyst power of the first one, And to me, being in healthcare quality and accreditation, I see two things coming up. First is communication, and second is the understanding. The communication amongst the staff, the healthcare workers, and communication between healthcare workers and the patient, or if patient is not in a situation with the immediate relative or attendant present during that. So, and again, I'm not going to the root causes of those communicating problem, because again, it's go to medical curriculum, it goes to behavior aspect, it goes to practices as well in different healthcare facilities. I'm just focusing on the communication, the right communication to the people who are around the patient. Usually, what is happening when patient attendants inquire, everything is okay, everything is okay, and everything is okay for 6 days, and 7th day, nothing is okay, patient has gone. So and it's not that there is a negligence at the part of doctors or healthcare providers or workers. It's not necessarily that. It's not there in most of the cases, because no healthcare worker would like to harm any patient. That's for sure, in my opinion. So, but it kicks off an adverse impression in the mind of patient attendants and relatives immediately. What's gone wrong in one day, that things have changed from east to west. So that's created a lot of problem. And then slowly, when it goes out of hand of the first catalyst to the second catalyst, and people start reacting wildly, and the rest becomes history. The second thing is understanding within the healthcare facility of the healthcare workers. See, it's a matter of fact that the healthcare workers are there in the healthcare facility around the clock. They are habitual and having habit of seeing what's going on around, from normal cases to little more serious and to far serious cases. So they are really habitual of it. It's nothing unusual for them. But for people who are coming maybe for the first time or second time into the hospital, it's not usual. is totally unusual for them. They have not seen sick patient, sick, the relative they are bringing it. So their mental is totally different, right? So they're we as a healthcare worker need to understand the mentality of the people who are around there. Now, coming back to what Parag has touched upon, the second victim. And in around the world now, the things have started cascading that the healthcare accreditation system has started incorporating some communication aspect, as Parag, you know, that how to strengthen the board of communication between everyone around. And it's not just communication, it needs to be effective communication. It's not something I just say and you just for saying the sake of say, and that's no. I need to talk to the people who are around the patient in a manner that they understand well. If they are convinced, I can guarantee you there is nothing going to be happen in the healthcare facility in terms of violence. There will be no second catalyst will come up. No one will come up. And I have seen examples in international scenarios where the doctor who somehow has done something wrong, but accepted to the family, and it has brought a lot of change in the whole healthcare ecosystem of that hospital. And the patient relative, and they accepted it, and they were more than happy that yes, the doctor has come forward to tell us that this was has gone wrong, this could have been better. So second victim is suffering because of not what he or she has done something wrong, but somebody else has done, but now he or she is feeling bad about that. This is a very mental torture situation for that. But the important thing is, are we publicizing that? Are we publicizing if any doctor or healthcare worker accepting something which may have been avoided? Are we publicizing them? We are not. We are not going to public and telling that this is what has been done, this is what is accepted, and as a positive example. No, we are not doing that. We are only doing something got beaten up, something got dead, something. We are all putting all in the negative sense. We are not bringing out the strength and the strong point in the healthcare community within the healthcare facility that should be leading as an example for people, for the society, for the community to understand that you are going to the hospital. It's not a guarantee that you are going to be safe. Not necessarily. It's not the doctor who is going to do that. So I think we need to put more emphasis, and I think the standards around the accreditation and quality improvement need to change, put more emphasis on these aspects rather than mechanical aspects of equipment and facility. Thank you very much. Or back to you, Parag. Thank you.
Thank you so much, Dr. Rana. I think that was very exhaustive. 3 to 4 clear points coming out. And before I move to my esteemed legal fraternity colleagues, senior colleagues, very senior colleagues, we have Justice Tripathi, we have Advocate Vajpayee, Dr. Shastri, and Advocate Richa. Before we move on to them, Dr. Pillai, over to you for a minute and a half for a quick sum up.
It's really a challenging task to sum up such an enormous and complex discussion in a minute and a half, but I'll try my best. So we see solutions emerging which is also broadly concerned with the research. Because of the constraints of time, I will not be referring to individual speakers, but the suggestions that have come up broadly correspond to physical improvements in the physical environment. So which means access control. That might also include better lighting, better security, and sometimes even good climate control within the hospitals, a cleaner environment, access to refreshments in the waiting room, and appointments management system. All of these physical improvements. Improvements related to training, let that be as medical students, let that be as healthcare workers. So the improvements in communication both between employees, which then reflects on the organizational culture. Because if your organization expects you to give out good news until it is exceptionally bad news, that is probably nothing that a nurse on the floor can do much about. Which again comes down to the pressures that corporate hospitals have to undergo. Someone mentioned going corporate, but only halfway through. I really relate to that. Also, then we spoke about response systems, that it should not only be about getting more stringent laws, but also about redressal mechanisms, that if you have a complaint that people can reach out to and get solutions before they actually resort to violence. So make violence difficult, make violence costly, but also give easier ways of getting the redressal they want. From the perspective of the police, rather than having more complex and more stringent laws, maybe the way to go is insisting on fast track court proceedings, so that complaints can reach their logical conclusion one way or the other, and people can all their lives. These are some of the suggestions that emerging. And we also saw that in the earlier, we saw problems with access to emergencies. And for example, from AIMS, patients have to be diverted away. And as Dr. Parag was mentioning, the money is also a problem, that you cannot always have MRIs and, all the scans everywhere. So I think then the solution there comes down to strengthening the primary healthcare, the rural healthcare, so that patients don't always end up at the doorstep of the corporate or of the tertiary care centers. Because once they come there, because they feel that is the only place where they'll get some quality of care and they're being turned away, that is itself a problem. A lot of solutions emerging, and in the positive time, I would summarize this, but I'm sure we will have to come back to many of these topics on follow-up events. Over to you, Dr.
Absolutely. Absolutely. Thank you so much, Dr. Pillai. Thank you very much to my legal fraternity. They've been waiting patiently. It's extremely difficult for lawyers to stay quiet and sort of listen and listen and listen. But thank you very much. Some of my favorite people, lawyers, because they've helped me in times when I've really been without any support. I'd like to start with Justice Tripathi. Justice Ravi Tripathi is chairperson of the Gujarat State Human Rights Commission. He's been a former member of the Law Commission of India. He's been a former judge of the Gujarat High Court. Sir, the question to you is very simple, sir. Where are we currently on legally ensuring things happen correctly in case there is violence? What are the deterrents that the law has put up against such violence? And any other views that you'd like to express? Justice Tripathi, since you'll be leading the legal brigade on this, we won't restrict you to time. I request you to maybe wind up in maybe 5 to 6 minutes. Over to you, Justice Tripathi, sir.
Thank you. Thank you very much. Good afternoon to everybody. It's really wonderful to have here all these views. Friends, one of the speakers said that we should have stringent laws. Let me tell you that stringent laws is never a solution. There is already IPC and there is already punishment of hanging for murder. But since inception of IPC, murders have not stopped and they are still taking place. Not only they are taking place, possibly more in number, maybe because of in proportion to the population. But then stringent laws is never a solution. Of course, there is a solution. Along with the stringent laws, if we are able to provide a connectivity to the crime, that is vicinity, that the crime has taken place on a particular date, and within a shortest possible time, if the punishment is inflicted on the wrongdoer, then it does have the deterrent effect. So that is very important for me. Second very important thing which I want to convey to all the panelists and all the doctors at large, that courts are not hostile to the doctors at all. Only thing is that courts have to look into the case basis, the evidence produced before them. And on the basis of the evidence produced before them, they always take the decision or make the decision on that. So friends, that is very important. Then what important thing which comes to my mind is that if we really want this entire problem to be solved, some of the speakers very well said that there has to be a special training to the medical professionals, starting from the medical college itself. So I think that is going to be a very important thing, because humanities, if they are introduced to the curriculum and if they are really taught well to the students, the things are going to change. Second important thing which I feel is that today, by and large, an impression is given that private hospitals are money-making machines. And until that impression is changed, that no, they are also service provider, these things are not going to change, because when you make it commercialized, the things are bound to take the shape like that. I don't remember any single incident. Of course, somebody referred to Alexander's case, but that was a very rare case where the royal entity was under the treatment. So that is a different thing. But otherwise, at least in our country, when we had our local healthcare system, nobody has ever come across that some Vaid is beaten by the village people, though he was taking care of the ill people in the village. So that is only because possibly this is a side effect or side outcome of the commercialization of the whole thing of the profession. Then friends, So far as resources are concerned, resources are bound to be a limited one. When you talk about any sector, when we talk about education, similar conference, if you hold on the education, you will find that no, resources are very less and it is required to be provided like this and that. But then friends, the best thing is going to be manage in the available resources and then gradually try to improve upon the situation of supply of resources so that the things can be taken care of better. Similarly, friends, in legal field also there are discussion and there are always rival contentions. Somebody say there are explosion of cases, and there is another side which says that no, there is exclusion of cases. I'll explain you what is explosion of cases and what is exclusion of cases. The studies are made, and according to the number, earlier there used to be 1 lakh cases, now there are 5 lakh cases, so there is explosion of cases. No, you have to study that what type of crimes are taking place and what type of crimes are reported exactly to the system. So there is exclusion of cases, and it is effect when it comes to domestic violence, when it comes to gender injustice, there are exclusion of cases rather than explosion of cases. So this is very important about the violence part. Also, one should be very careful when you say that so many cases have taken place. But then you have to study about these cases in proportion to the services available and the number of people have increased. Friends, Dr. B.K. Rana said that violence is not acceptable. Well, I'll say counter by saying that negligence is also not acceptable or equally not acceptable in the legal field. I don't know whether your conscience bites or not. When I hear a news or when I read a newspaper report saying that some doctor forgot the sanitary, 12 or some instrument inside the stomach of a patient. How will you feel about that? So when Dr. Rana says that no, violence is not acceptable at all. Similarly, sir, negligence is equally not acceptable, especially in the field of the medical profession. Normally it is said, and especially in the films you will find, that if doctor commits a mistake, the man gets buried in the ground. And when an advocate commits a mistake, the man gets hanged, so he gets higher the ground. But then, friends, I'll still say that an advocate's mistake may be pardonable because 90% cases it affects only the property. But in the cases of medical, it affects the person, live person. And it's very difficult for any human being to see his patient relative dying on account of some negligence. So what is the solution is a proper communication, which everybody has spoke. I repeat that because I like it, that there has to be a very effective communication. In the matters of PASA, that detention matters, it is specifically provided in the law that you should communicate the cause for detention to the person in the language he understands. See, important is that it is communicated effectively, it is communicated properly so that he is able to understand and he is able to take care of that. Similar thing should happen with the medical profession also, that the relations which are there, well, I being given a dignity, when sometimes we visit the hospitals, we are said that you just wait. Instead of that, if somebody is there, not the senior doctor who is going to operate my relative or anybody, but at least somebody should be there to tell me, say, sir, it is like this, and you need not worry about it. The things will be taken care of. I am conscious of the fact because my general practitioner doctor, who happens to be my friend, he said, sir, in medical profession, it is never 2 + 2 4. It could be 2 + 2 5. It could be 2 + 2 3. Because the same tablet, same drug, if you are taking, it may not have given a reaction, but it can give a reaction at any time. So I can understand that because when the things are explained to me. So friends, this I feel that this is important. And sir, along with this, you should try to involve media people, and there should be some check on the media people because the way they publicize, that makes the difference. If they publicize positively, well, the things are taking shape positively. If they're publicized negatively, the things are taking negatively. Friends, so far as law is concerned, law can take care of the situations, but human behavior is beyond that. And human behavior can be corrected and can be, mended by having the proper training at the professional level and also the communication level to the relations of that. If any question will be there, I'll be too happy to answer. Thank you very much to the organizers for giving me this opportunity.
Thank you very much, sir. And just to put in a little naughty note there, Justice Tripathi, both against violence as well as against negligence, we do have the esteemed judiciary to count back upon. So I would actually hope that in both these cases, we do come forth and go to the judiciary to seek the support of the judiciary. Because if everybody starts taking the law in their own hands, we're all going to be blind. The whole world is going to be blind. Thank you very much, Justice Tripathi. I'd now like to request, give me a minute, please. There are times when even this moderator fumbles. My apologies. I'd like to now invite Dr. VVLN Shastri. Dr. VVLN Shastri is legal counsel, Lex India Juris. He's a PhD in law and public policy from the Walden University in the United States. And he's also the first software business analyst of India, respected by Business India. Dr. Shastri, your opinion, the law and violence against healthcare providers, is it adequate? Do you think we need more? What exactly can be done to reduce the activity, the incidences of this thing? Okay, thank you.
Thank you. See, when healthcare providers are in conflict with the clients, patients, customers, there erupts the violence. And it includes verbal, emotional, sexual, psychological, physical, and cyber intimidation, and also threats, abuse, and occasionally even extreme bodily harm and injury. Likewise, when healthcare providers are in conflict with their own healthcare system, violence also arises because of the long working hours, up to 120 hours a week for doctors, and also poor quality of emergency care infrastructure, poor mechanism for grievance redressal within the hospitals, delayed legal procedural outcomes basically is also a threat for doctors, and a poor emergency network among hospitals and poor communication skills of the healthcare workers. These are all some resource-oriented conflicts which doctors face, healthcare providers face, and they get into violence basically due to this. Now, to deal with this kind of violence, what kind of alternative, what kind of legal mechanism is available for these healthcare providers if we strictly analyze? Prior to healthcare, what you call this epidemic diseases ordinance, which became an act actually in 2020, the healthcare providers were covered under Indian Penal Code 1860. Indian Penal Code covered all kind of violence against the healthcare providers, but its implementation, I mean to say, in terms of its effectiveness, is slow in terms of timelines. That is making people feel that there is lack of action on the part of judiciary and the state, and that is leading to an increased violence to some extent. And what kind of, if you look at the kind of sections between the epidemic ordinance and which became again an act, and also the Indian Penal Code, almost all the sections of Indian Penal Code and Epidemic Diseases Act covers the same kind of what you call remedies in terms of legal remedies for violence, and also violence causing grievous harm, and also damage to the property. These are some of the reliefs provided, in these two remedies, that is remedy through IPC and remedy through Epidemic Diseases Ordinance Act, basically amended. And also in between, in 2019, there was a Healthcare Service Personal and Clinical Establishments Bill 2019, which hasn't been enacted due to its referral to, again, ministries back. But it also covers the violence causing grievous harm and damage to properties. So act-wise, definitely there are remedies available. The remedies, in how long time they are going to be what you call sanctioned or are going to be provided to the victims is what the most important thing. That is where actually special courts may need to be introduced in India for dealing with these medical cases and violence on healthcare professionals. Only then there will be a speedy justice available. Otherwise, if they go through the normal court system, I feel it's going to be long for these medical professionals, which in turn makes them demoralized and demotivated in their profession. That's what is my feeling. Yeah.
Thank you so much. Thank you so much for a very, very crisp conversation and a few salient points put forth, Dr. Shastri. I'd now like to ask Advocate Ms. Richa Singh, who is the General Counsel for Medanta Group of Hospitals. I just want to give a little prelude to Advocate Richa. Private hospitals generally desist from lodging cases unless there's been any major substantial damage. Why is that so? Maybe I'm wrong. Maybe it's more with the west or the south. It's more maybe it's aggressive with the north. And what are some of the key points that private hospitals have put in to ensure that there is least damage to man, machine, and the milieu in which healthcare is provided? Because you must remember that healthcare continues to be rendered for the other patients who are there. At some stage, there is a moral as well as a legal binding on the doctors and other healthcare providers to continue providing healthcare. Otherwise, they could be sued for negligence to the other patients. Advocate Richa, over to you. How does private healthcare or corporate healthcare cope with this? Because you are seen as the pioneers in setting up systems and processes. Can you hear me, Advocate Richa? We seem to have a little. Advocate Richa? Okay, I'm going to deal with this with legal cutting edge time management. There we are. Advocate Richa, did you hear my question, ma'am, or should I repeat?
I'm really sorry. If you can repeat, that would be very nice.
Okay, corporate healthcare has always been at the front end of setting up systems and processes. How have you in corporate healthcare in the north or across wherever Medanta Hospital is? How have you actually managed to set up systems and processes to prevent violence in healthcare? And generally, there's a feeling that corporate healthcare desists from reporting such miscreants to the law. Is there a fear of rebuttal from the law? What sort of pressures does corporate healthcare face from the policymakers, local politicians, goons, etc.? Over to you, Advocate Richa. Thank you. You have 4 minutes.
Everyone.
Yeah.
Good morning, everyone, and thank you for letting me participate in this. I've heard the views of all the participants, and they were very valuable. As far as corporate hospitals are concerned, I think the biggest challenge which a corporate hospital faces is the fact that when the patients come into a corporate hospital, like maybe a Medanta or a Fortis or a Max or any other such hospital, where they are paying, according to them, very hefty medical charges, then there is a concept of commercialization that comes into the picture, where they expect it's a service they are deserving, and the service needs to be rendered, and the outcome of that service is my patient needs to get better. They do not understand the medical complications and the comorbidities. They just expect that because they've paid a certain money, the end result has to be a good patient, happy patient walking back home. And when that does not happen, their response is, I have paid the money, but unfortunately, I have not received the service. It is very difficult to explain to such patients and attendants the medical complications, because they compare the prices with a government hospital, but they don't understand the capital cost that goes into it. And of course, then the other problem is when the charges are very high, the total bill becomes very high, then money becomes an issue and they don't want to pay, especially in death cases. Now, what efforts which we have taken as a corporate hospital to deal with things like this is one, counseling. We have experienced and we emphasize on counseling a lot, where a patient or a family is counseled on a daily basis about the clinical condition of the patient, the line of treatment, the charges and everything. So when it happens on a daily basis, they are mentally a little prepared about it. Second, we have, as Dr. Kulbir Singh said, we also follow the grief counselor concept, wherein in case of a death, before death does happen, doctors do realize that the patient is going to reach a certain end. We involve grief counselors. And third is that we have licensing with police officers and the police station, wherein wherever there is a mob mentality or wherever we see that the attendants are getting aggressive and there are chances of them getting violent, we engage the police officials in advance. So we don't wait for the violence to happen, we engage them in advance. So these are the efforts which we try and implement. And fortunately, till now, we have not had any such. Of course, it depends from unit to unit, location to location. The scenario is different. Ranchi is different from Indore to Lucknow to Gurgaon, but pretty much it's it's the same everywhere. Mob mentality and the attendant who's expecting that medical care is service. So those are my thoughts on this.
All right. Thank you very much, Advocate Richa. Appreciate your answers. I now, before we move on to the last this thing, I'd just like to say that this we've heard it from all the three aspects. We've heard it from the doctors, we've heard it from the lawyers, and we've heard it from the social scientists that for some reason healthcare is considered a business. There was a study recently undertaken by the AHPI in conjunction with Indian Institute of Medicine, Indian Institute of Management, Bengaluru, and where clearly states that even in government hospitals, the cost of running a bed on a daily basis is roughly rupees 18,000 in a metro city. The same cost in corporate is passed on to the patient at a subsidized rate, whereas in the government, it's fully subsidized. So I think somewhere our government needs to pick up on its responsibilities and start communicating to our patients who are taking healthcare and government for granted that government healthcare also costs. That will probably reduce the impression of healthcare as a business provider. And last and not the least, the person who is extremely passionate about healthcare and law being sort of important tenets of his own life. Somebody who has got me interested in the law now for almost over 7 years and whom I have had the privilege of working with for the last 6 years. I request and ask Advocate Mahendra Kumar Bajpai, who is the Advocate Supreme Court of India, Honorary Director of Institute of Medicine and Law, Editor Emeritus Medical Law Cases for Doctors. Advocate Bajpai, your views. Is the law adequate? What can be done to deter violence within healthcare institution against healthcare providers? Over to you, Advocate Bajpai. Thank you.
Thank you, Parag, for those kind words. And I'm really sorry that you have been very unfair to me. After Justice Tripathi has spoken on law, you can't expect another lawyer to speak on law. So that is closed. Fortunately, Dr. Ved Prakash Mishra spoke only on one small topic, that is education. So there is a little room for me to speak. Otherwise, I would only have said thank you, very good. Friends, real problem in India is that we don't take healthcare serious. No one takes healthcare serious. About 3 weeks back, I was briefed in a matter to appear before the Honorable Supreme Court. Some group of doctors was trying to challenge the Consumer Protection Act. And we were trying to look into the legislative debates. In the Consumer Protection Act 2019, doctors were a part of that act, or rather very expressly doctors were included under the ambit of Consumer Protection Act. And then slowly that was deleted. So to interpret statutes at times, you have to look into legislative debates. I could not find a single sentence, and I'm not blaming the Honorable Minister who is now no more with us, even other parliamentarians. Why doctors should be included, why doctors should not be included. We are really not serious about healthcare. So very critical for any society, any nation, but we are not serious. I come across patients, friends, relatives. Doctors are not permitting me to get inside the ICU. Fine, someone has to explain it to them. Why patients, attendants can't go inside ICU? My uncle is dead, but still the ventilator is on. Law does not permit a doctor, law does not permit a hospital to just take off the ventilator. The Honorable Supreme Court has intervened in the Common Causes Code, but the procedure that has been laid down, We have not even initiated registering of advanced medical directives. Friends, at times doctors come, and when I see the bills of corporate hospitals, 2,30,000, doctors bill 15,000, and still it is the doctor who is blamed. There has to be debate. There has to be awareness. There has to be seriousness. Patients, when they are not patients, have to be explained about healthcare. And especially amongst the lawmakers, amongst the policymakers, I don't find this seriousness. Friends, I'll quote 2 excerpts, and that's all. Both of them from Supreme Court judgments. Most of the panelists, as well as the ones who are viewing this, happen to be doctors. Please know a very fundamental aspect of law. Courts are not the place where law is made. They don't decide the policy. It is the job of the legislature. It is the job of the regulator to make policy. Unfortunately, because the legislatures, because the policymakers are not making policy, the courts have taken upon themselves to make some policy changes. One of them, way back in 2005, Jacob Matthews case. The Honorable Supreme Court said you can't arrest a doctor for negligence. It will be a great disservice to the society. Protection which ought to have come from legislation came from the court, and I'm quoting a small excerpt of that judgment. Para 29 and para 30. Justice Lahoti had delivered this judgment in 2005. I'm quoting, a medical practitioner faced with an emergency ordinarily tries his best to redeem the patient out of his suffering. He does not gain anything by acting with negligence or by omitting to do an act. Discretion, I'm reading para 30. Discretion being better part of valor. A medical professional would feel better advised to leave a terminal patient to his own fate in the case of emergency, where the chance of success may be 10% or so, rather than taking the risk of making a last-ditch effort towards saving the subject and facing a criminal prosecution if his efforts fail. Such timidity forced upon a doctor would be a great disservice to the society. Something like this ought to have been said in the legislatures. When Consumer Protection Act was discussed, when other legislations regarding which concern doctors and healthcare are discussed. Another paragraph, Samira Kohli's case. The Supreme Court said we don't want American laws in India because India is an illiterate and poor country. Let us, I'll read what Justice Ravindran has said. Healthcare like education, Dr. Ved Prakash ji has dwelled upon it. Healthcare like education can thrive in the hands of charitable institutions. It also requires more serious attention from the state. In a developing country like ours, where teeming millions of poor, downtrodden and illiterate cry out for healthcare, there is a desperate need for making healthcare easily accessible and affordable. Remarkable developments in the field of medicine might have revolutionized healthcare, but they cannot be afforded by the common man. The woes of non-affording patient have in no way decreased. Gone are the days when any patient could go to a neighborhood general practitioner or a family doctor and get affordable treatment at a very reasonable cost with affection, care, and concern. Their noble tribe is dwindling. Every doctor wants to be a specialist. The proliferation of specialists and super specialists have exhausted many a patient, both financially and physically, by having to move from doctor to doctor in search of the appropriate specialist who can identify the problem and provide treatment. What used to be the competent treatment by one general practitioner has now become multi-pronged treatment by several specialists. Problem has been discussed in its entirety. Time has come, friends, when more such discussions are required. Seriousness is required, and that is all what I would want to say. Parag, thanks for giving me the opportunity to speak.
Thank you very much. I'm just going to take a minute or two and before I hand over to Dr. Pillai, I would like to add a comment or two. But once Dr. Pillai kind of summarizes the legal fraternity's comments, I'm going to do a rapid fire round, and rather than me asking questions, I'm just going to pick people's names in the order that they spoke today from the morning, and I'm going to give you a minute each to highlight 3 important points that, in very succinct format, please, 3 important points that you would like to contribute to the white paper, which make actionable sense, which actually would help our government, our policymakers to draft laws, regulations in any direction, whether it's the law or whether it's healthcare, in any direction. I'd just like to say one more thing. Somewhere there is a feeling that, and there's a paper by Nikhil Pandit on the Wire, which says that behind the violence, a failed system. There is a problem of shifting the burden of care. Suddenly, there's a shift of burden of care, which was evidenced across the country. States penalized private healthcare by forcing them under the Pandemic Act, which was accepted by private healthcare. But now there is this whole moot point of everybody wanting to be taken on under the Pradhan Mantri Jan Arogya Yojana, which actually is, I think right now there's more noise about Amazon, which Reuters keeps writing about. Probably that's the next case that's going to go up. Private healthcare versus Government of India in the Competition Commission at some stage. I think lawyers and doctors both should gear up for that. I think there's a huge focus on structural violence and systemic inequalities that has never been seen before, as was seen in this pandemic, where people actually did not have oxygen to breathe, even in private healthcare. Lot of inadequacies on both sides of the government as well as private healthcare. On one hand, it's money. On the other hand, it's about manpower. It's about resources. Time we actually gave a clarion call, wake-up call to everybody and reduce these inadequacies so that socially we are back on track. Our society needs us, and that's what we need to focus on. Dr. Pillai, a minute and a half to wrap up and tell us what our lawyers spoke about. And then I'm going to quickly go rapid fire to each one of you. Dr. Ved Prakash Mishra ji, you will be first, so you can probably start thinking about your 3 clear points. And then we'll go quickly rapid fire because we do owe it to our audiences to finish up in time. Thank you very much. Let's move. Dr. Pillai, over to you for 1.5 minutes. Thank you.
Justice Tripathi opened this round by highlighting the importance of deterrence, and that having stronger laws is by far not maybe a necessary part, but definitely not a sufficient by itself to address solutions. The importance of media engagement was highlighted more than once. And I think this discussion would have been richer if we had a representative of the media, because the media itself is a corporatized ecosystem. And I think in subsequent rounds, we need to engage with the media more. Grievance redress mechanisms, infrastructure, and special fast-track courts were mentioned yet again. And the expectation of a service being not delivered to an expected standards, which is the whole ethos behind consumer protection. And how that contributes to reluctance to pay, or maybe perceived sense of injustice has been highlighted. So I would want us to reflect on possible pooled payment mechanisms, maybe with co-payments, and to avoid impoverishment, but also to change this conversation around I have paid for a service, I haven't received it. So should healthcare, like in most of the Western world, should become free at the point of care? But then what are some of the safeguards we need to put in place that doctors or hospitals, it doesn't become supplier driven. So some of those conversations need to happen in subsequent rounds. It has highlighted and quite effectively that the true costs of healthcare need to be brought out. So healthcare is completely subsidized in the public health system, and even in the private sector, it is partially subsidized. And this is a really big issue because that then leads to what Vajpayee sir very eloquently brought out, this whole idea of a cavalier approach to healthcare. The legal vacuum and the lack of deliberations in the parliament or other legislative bodies, it is a long-standing issue and in India and probably beyond the scope of this discussion. But delegated legislation where the courts are forced to step in, yes, and something we need to work together. And the responsibility, the responsibility beyond what happens within the specific event, to identifying the social determinants of strengthening the health system, the supply chain, and the wider ecosystem being engaged. So this was brought out in the sense of how do we bring health education, both specifically for the policymakers, but also for the lay public. I would end my time with a reflection on Article 21, because the frustrations that the courts have faced finally forced the courts to bring right to life to also include healthcare under it. And subsequently, it was enforced by, we know the Paschim Banga Khet Mastur Samiti case and many other cases where this was institutionalized. But essentially, as a health system, we have the right to health, but we don't have universal health coverage in a country in which, for example, 90% of subspecialists are working within the private sector. So these sort of distortions of supply side and demand side are what we need to address, in my opinion, to reach to the root cause of the issue. And finally, there is de-skilling of the general practitioners. There is devaluation of general practitioners. And till the day we acknowledge that a general practitioner who knows the family and the community and the patient brings as much authority and value to patient care as a subspecialist in a city, we are not going to address this problem. Thank you. Over to you, Dr. Parag.
Thank you very much, Dr. Pillai. As I said, I've given a good 1.5 minutes heads up to everybody, to all our esteemed panelists. At the very outset, let me just tell you that in case I've inadvertently stepped on people's toes in terms of time management, sincere apologies. That was a mandate given by IML and NCML, so apologies there. Over to you, Dr. Ved Prakash, sir. Your quick 3 contributions.
Absolutely, Dr. Parag. My first contention is for the equipping of the health professionals to be tackling the situation that we are put across. Number 1, the education has to be an integration of hand, head, and heart. In terms of the undergraduate education having worked out in that way, alignment of the same to postgraduate education and linking the same to subspecialty education, first requirement. Second requirement, meager educational process on this count will not suffice. It has to be linked with continuous professional update through continuing medical education. Therefore, allocation of specified credit hours for the renewability of the registration in the specific domain of heart education, as we call in terms of the professionalism and altruism. And third, linking the healthcare delivery system, aligning it with the dispensation system on the ground, that the patients in this country can be broadly categorized into 4 categories. Number 1, illiterate and ignorant. Number 2, informed. Number 3, enlightened. And number 4, empowered patients. Therefore, in these 4 categorizations, these 4 channels keeping in mind, in this paradigm, the entire training and continuous medical education, so that the entire lifelong services on that point of count can be worked out in this particular diligent manner. Thank you very much.
Thank you very much. Your conversation encourages me to apply for a sabbatical under you, sir. I'd request Dr. Jailal. I don't see him in his chair. If I'm audible to him, Dr. Jailal, Indian Medical Association. Okay, we'll come back to you. Is Dr. Ravi Shankar there, or has he signed off? He's signed off. Okay.
Hello.
Yeah, Dr. Ravi Shankar. Yes, sir. Quickly, crisply, 3 salient points that you'd want us to put actionable points in the white paper, sir.
Yeah, human emotions cannot be controlled. A good communication with a video recording is going to help you later when you have a problem. So today we need to go in for a video recording. There should be a mechanism where the case of violence at the earlier. If they don't reach the point of case earlier, I think the government takes action against people. But when something goes wrong in front of a hospital, nobody takes action. Every government institution have a police outpost in there within the campus, but that doesn't exist. then there should be a mechanism where they should peak earlier. IPC has been enough inadequate, but not comprehensive. You know, the quackery could not be eradicated, but that dowry could be stopped or reduced, all because of a comprehensive law that's been effective. A quick redressal mechanism is absolutely needed so that it gives a confidence for these patients who are really angry or they feel that they have been victimized. A redressal mechanism which can happen within 3 to 6 months. That will have to be taken care of. And one big major thing that has to be given to the public is cost of health care is not on the professional side. It is on the infrastructure. It is on the biotechnology that is available. It is on the land cost. When people can accept buying a distillery water for 150 rupees in a star hotel, then they should understand what should be the cost or the excise duty or the land cost or everything that happens in the hospital industry. Professional services are less, the extra services that people should be able to understand. It is a duty of us to do that, and media should have a regulation on how they have to talk on the healthcare issues. These are the things I think comprehensively will be very helpful. My idea for it. Thank you. Thank you very much.
Thank you. Thank you, Dr. Ravi Shankar, sir. Dr. Jagannathan.
Yes, sir.
Your quick 3 crisp comments on what would you like to get? Yes, sir.
First thing people must realize is every death is not a negligence. Cases against doctors are well recognized and active. We are dealing with almost 50 RTIs per month. There are redressal mechanisms. A person who's on call, speaking from a medical college point of view, and obviously from a private hospital point of view, they're not going to keep a palooka to manage major decisions. But a person who's on call in emergency ward and casualty is senior enough to take major decisions. My final take is punish the perpetrator, be it the doctor or be it the patient or relatives, by a due process of law. There are avenues available, it seems, for punishing doctors, and the number of cases of them are on the rise. But don't take the law in your hands. That's all the message I want to say.
Thank you, Dr. Jagannathan. Thank you. That was very crisp. Dr. Satpathy, over to you. Your 3 points that you'd like to get into the white paper, what do you think is absolutely critical?
You see, it's rarely that one gets a chance to, speak to, the legislators. But you see, I think the political parties should try to bring healthcare delivery or healthcare as a right within their mandates. That is something that is not happening. More debates and deliberations before passing laws, because the NMC also, we have seen that, things were, passed very, very quickly. For the government, yes, definitely budgetary, allocations needs to be increased. And, even there is a cut this year also, that 20% cut in GIA general. So the cuts on healthcare should not be there, especially in pandemic years. That should definitely be there. And for the last 10 years, we have been saying that we would go up to 2.5% of the GDP, which is not happening. So that needs to happen. For the regulator, that is the National Medical Council or the NCI in its earlier avatar, encourage family medicine and general practice. You see, we are actually going more in the super specialists, way, which can create, problems. And there's no lack of, safety net. Between specialties, the patients are falling down. So that needs to be encouraged. Hospitals should focus on what they can do, because that is a very varied, spectrum. In AIMS, you can have access control, you can have, bouncers, or you can have plainclothesmen, you can have CCTVs, but the same is not there, in other smaller, healthcare facilities. So they should focus on what they can do. And I'm sure small steps can be taken by each one of them to reduce the friction points. I think that is all from my side.
Thank you, Dr. Satpathy. Incidentally, the maximum number of seats that don't get filled are DNB family medicine, just a point of interest.
That's right.
Anyway, Dr. Gurbir Singh ji, sir, your quick 3 salient points on where do you see as the solution? What do you see as the solution for this? Dr. Gurbir, sir. Yes, sir.
Yeah. Now, many points would be repetition, so I would come down straight to the 3 points of mine. First, namely, is when you find a person with a protracted ailment who has come to you in a tertiary care hospital, have free-flowing, transparent, regular communication through multidisciplinary team consults under video coverage, which will deter the individuals to go back on their own schemes later on. Secondly and thirdly, when you know an imminent thing is about to happen, there is a feeling the person who has paid money or is losing a very dear person and who may have been the only breadwinner, there is an emotion which will come up, which is anger, isolation, and helplessness. Therein, you must have mature, sound grief counselors to mitigate this thing into a situation which becomes more compatible with social norms. Thirdly, declare the hospitals as protective zone declaration should be there. Ring fencing mechanism or management to isolate the potential troublemaker with care, empathy, and in an area away from the other attendants, etc., because they become those bystanders who stand up for just the tamasha. Okay. And also liaison with your police, wherein they can mitigate the political pressure and from the goons outside. This would be immediate for the corporate hospitals to mitigate violence.
Thank you, sir. Thus spake the voice of wisdom. Thank you very much, Dr. Goodby, sir. Appreciate that. Dr. Rajput, sir.
So 3 points.
Yes.
The first point is that in the 5th year, when the students, they are studying, right, or even the paramedical staff, the emotional quotient classes has to be inculcated, and it has to be repeated every 6 months, which is very, very important. Like the way CME, we get the credentials, it has to be there. Then only the better communication is going to happen, and then only we'll be able to console at any level and every level, either from a junior doctor to the paramedical staff to any of the senior doctor. This is point number 1. Point number 2 is that there has to be statutory warning pad should be there, or there should be a notice board where if any person is going to mishandle the people there, what are the complications are there. That has to be there in the every hospital and the every ward, because people, when they see, at least they will have that reflection that they are going to have that penalty if they will not have the good behavior. It is a part of the prevention. Third thing is, sir, there has to be I told you about this Aadhaar card type of system. If somebody is doing it, there has to be there in that, so that people should understand that this person is towards the negative side, so that in future the person should be penalized in different type of the ways. Because this is the way we can prevent. It is only we can make the difference instead of going there and somewhere and asking about the help. So this is the way that I feel. Thank you, sir.
Professor Dr. D'Souza. Sir, over to you for your 3 crisp points on what you think could actually prevent or deter violence in healthcare.
Thank you. After listening and to all the important panelists here, three areas. One is, of course, to continue with this education reform, bringing in the training, the emotional intelligence, the communication, ethics, and humanities, and a continuing process. The second would be a focus on quality and some supervision for quality in all the institutions. And the third would be measures to improve trust in doctors and the hospitals and the healthcare system, with public measures that will have an end result on improving trust from the patient and from the community factor. Thank you.
Thank you very much, Professor D'Souza. Before I move ahead, I'd like to ask Dr. Rana, your 3 salient points.
Thank you so much, Parag. And I think, first of all, one of my point would be completely, and thanks to Justice Ravi Tripathi sir, not to agree with my statement. And that's all I have been doing for the last 20 years. No violence, no negligence is acceptable. And that is what we are working in the field, that how we make sure patient safety. So first point is the healthcare facilities must start focusing toward person-centered care, not individual disease treatment. No more disease treatment, but the individual person taking the family accomplishment in the center of the care. Second thing is about the patient and family education. That's very, very important, and we need to put it into place, that make sure that there's good education going through to the family and patient to avoid any miscommunication and anything. The third point I would say is about the oversight organizations like accreditation bodies to bring the international best practices in this area, where a lot of work is being done in the West, where we can learn from them. We need not to reinvent things. We can bring those best practices and start looking into the facilities, like Professor just mentioned about the quality. That is what we are doing in accreditation bodies. So I think the hospitals who are already into the system, they should start practicing those things to minimize any sort of things which are happening in the hospitals. Thank you very much, Parag.
Thank you, Dr. Rana. I now request Shauli. Shauli, your three salient pieces on what you think can improve the situation.
Thanks. I think, first of all, healthcare as an industry or a sector, what is non-negotiable for us, that it has to be violence-free, it has to be more inclusive, consumer-centric, and sensitive towards each other and towards, outwards as well. So for that, policy reforms should go hand in hand with the system strengthening behaviors and practices with a multi-stakeholder approach, because we always say this in the social side that not one person or one institution can make those changes. So secondly, healthcare institutions, along with judiciary and justice system, must ensure prevention of any sort of violence and also prevention of re-victimization. I think that got somewhere missed out when we were discussing this, that the process of justice system itself sometimes gets very scarred for the victims or survivors. So it needs to be more inclusive, time sensitive, and fair and redressal systems are required, even internally when we talk about like workplace systems, for example. Thirdly, the investment on early prevention systems through a continuum of skilling, evidence-based programming, sharing best practices and learning. I think these are some of the key points that other esteemed panelists has already made. But I think nevertheless, to end it, it's a comprehensive effort which is required with the ecosystem lens to ensure the well-being of the healthcare providers as well as their consumers and their families as well. Thank you.
Thank you very much. Dr. Goswami, over to you, sir. Your three salient points that you'd like to focus on. Dr. Goswami?
Sir, you are on mute. Dr. Goswami, you are on mute.
You are on mute, sir.
Yeah.
Thank you, sir.
I'll confine my just 3 points related to police work. So in my view, emphasis must be given to the scientific investigation, better collection of evidence, and speedy trial through fast track courts so that deterrence effect should be there. Further, number 2, for empowering the patients, negligence by doctors must also be taken seriously, but with diligent efforts. The third, the rule of law must take its own course, be it a patient or a doctor. So we should not discriminate. Once somebody is at fault, he should not given any extra weightage. Thank you very much for my.
Thank you, Dr. Goswami. Dr. Das, Dr. Institute of Social Sciences. Over to you, sir.
Right.
Dr. Shankar Das. Yes, sir.
Thank you so much. Yeah, I just have a few points to remember. All of you have been talking such a valuable lessons. But there is a very important at the moment is this, we need to have a documentation and research. And the research has to be very systematic from the multi-stakeholder perspective, which possibly may give us a good lessons for an eclectic and very holistic, way of approaching this issue. From the legal point of view, doctor, patient, community perspective, all should be part of a very exploratory kind of a study. This is one thing which is particularly missing at the moment. Only we are reading and learning from the anecdotal data or media coverages, which is not very scientific in terms of going ahead and developing good lessons. This is first point which I wanted to say. And the second part of our, approach should be, how do you humanize this healthcare system? We have already dehumanizing this healthcare system. We need to be more of a humanizing this healthcare, and particularly for the prevention of violence will take care and promotion of the concept of therapeutic community. Therapeutic community is not today, as you very rightly say, in England and many other countries have been doing. It's a very old concept called therapeutic community by Maxwell Jones. Everybody feels welcome in that community. This is my second part. And the third part is that the state has to take more responsibility in terms of bringing more stakeholder, particularly the market, civil society, for the future planning and future investment into the healthcare, which is extremely important. And that is all which I wanted to say. Thank you so much.
Thank you, Dr. Das. I request Justice Ravi Tripathi, sir. Okay. While we wait for Dr. Tripathi, can we ask Dr. Sastry to kindly put up his salient features, please, sir?
Yeah, thank you. I feel that lack of fear for law has to be undone. Though Section 3A of Epidemic Disease Amendment Act provides that the inquiry or trial must conclude within a year, but this period must be reduced through special courts or fast-track courts mechanism designated for trying these cases, and must be made applicable to normal periods also, not just restricted to epidemics. That apart, institutions, healthcare policymakers, media organizations, and law enforcement agencies must work together for widespread public awareness to counter misconceptions and to exhibit responsible behavior. Apart from this, the last one is the de-escalation measures, that is training and increased security, must be implemented. Furthermore, law enforcement agencies must be trained in non-violent methods of crowd dispersal and control to manage peaceful protests by healthcare providers over legitimate issues. Thank you.
Thank you very much. Advocate Richa, I don't see her icon, so I guess she's signed off. Justice Ravi Tripathi, has he joined back? No. We will come back to Dr. Tripathi in case of if he comes back. And last but not the least, of course, our very own Advocate Mahendra Kumar Bajpai, sir. So your voice is muted. Yep.
Three important suggestions from this convention. The first one obviously happens to be coming from Dr. Ved Prakash ji, reforming the medical education system. The second one about speedy trial, and as put by Dr. VVLN Shastri, the provisions are already there in the Epidemic Diseases Act. 3A says that investigation has to be completed in 30 days and trial within 18 months. So the policymakers are aware that the deterrent effect will come only when the trial happens quickly. So in the laws which are in place, or if a national law comes in, speedy trial must be there. And the third thing, obviously, a good suggestion given by Dr. Gurbir, grief counselors, whether it's public hospitals or private hospitals. These are the three take-home points for me, Dr. Parag. Thanks.
Since I see Advocate Richards joined back, Advocate Richards, three salient points that you'd like to add to the white paper? No, nothing. Is Justice Ravi Tripathi back? I think, but his points have been clearly articulated by him. So in case he joins back, we will definitely get him to speak again. I think we've surpassed one of the points. Dr. Pillai has been kind enough to come in intermittently and complete his responsibilities, which is supposed to be the end. So we summarized at the end of the medical piece, we summarized at the end of the social scientists and qualitists and all those other pieces, and then we came back after the legal piece. So Dr. Pillai, thank you very much. Through you, through the kind offices of the convener, I'm going to hand over the baton to Dr. Wankhedkar sir for his summarization. Is that okay, Dr. Pillai sir?
Thank you very much for this opportunity, Dr. Parag, Ravi sir, Bajpai sir, and an esteemed panel. Such a passionate discussion, such a powerhouse of empowered voices in a room. I'm sure we'll reach solutions. Thank you very much.
Thank you. Dr. Wankhedkar sir, as chairperson, over to you, sir.
Thank you, Parag. And I think I can take the liberty of extending my 5 minutes as a chairperson to a bit 2 more added minutes.
7 is fine, sir.
Thank you, Parag. First of all, let me thank all the esteemed panelists. What was expected in the morning, more than that has come out of it. And I am sure this Amrut will be converted into a proper white paper so that the community at large and thereby the opinion makers and the lawmakers will be sensitized at least in understanding this malady. While summarizing there are certain preventive aspects and certain things which are to be done after the violence has occurred. Broadly, we can categorize them in these two broad categories. But before overall taking a holistic view of the entire issue, let me just take forward what my convener, Dr. Pillai, has done, and I would be just in very short briefing upon the points various eminent panelists has deliberated upon, which are very obviously being a originator of the ATCOM module, which is very much needed. He very rightly explained upon it. Dr. Jagannathan, I was so happy that he is also a MARD activist like what I was, but I here disagree with Pillai sir that it was never infamous, but it was always a famous organization and still it is a very relevant organization. He very clearly pointed out the issues of violence in public hospitals, which are mainly systemic in nature, where our junior doctors and resident colleagues have to bear the brunt for no fault of theirs. And crisis management teams he mentioned, which I would like to inform this August House that we through the Indian Medical Association have lot of all our branches have formed the crisis management team even for the private sector, where a group of doctors, including medico-legal experts, reach the violence spot and try to diffuse the situation and further follow up these cases, which was also very important. Dr. Satpathy gave his very good experience on the Premier Institute of All India Institute of Medical Sciences, and everyone dealt about this, that healers to doctors to medical technicians, this journey needs to be reversed. Now what we are seeing is that previously we were treating patients holistically. Then probably our generation was treating them as doctors. But I see the people are not only treating diseases only, but they are treating investigations. Those category of medical technicians, this process needs to be reversed and we need to be healers where most of these issues will be addressed. While saying so, Dr. Rana mentioned about person-centered medicine. I am very closely associated with the International College of Person-Centered Medicine. We hosted a conference, international conference in 2018 also. This is but our own traditional medicine concept that treating a person as whole. And now we are trying to learn it from the West. But that is what exactly is healers is. Here the debate also comes that evidence-based medicine versus clinical-based medicine. Everyone tries to eulogize the grand old days where their own neighborhood family physician used to just see the pulse and make a diagnosis and treat. They forget that medicine has progressed a lot. 47, our age expectancy, average life expectancy was 38 years. Today we are at 62 years. That is because of progress of medicine. All our health parameters, IMR, MMR, this is due to progress of science. Yes, we need holistic healers. And that not necessarily is the general practitioner. This is again a misconception. I, as a surgeon, need to be a family surgeon of that particular family. A super specialist, a neurologist has to be a family neurologist of that particular patient. The concept is treating the patient, the person, Dr. Ravi Wankhedkar, having an epilepsy seizure. Not just treating the EEG of Dr. Ravi Wankhedkar. That is applied across the board, whether you are a family physician, you are a specialist, you are a super specialist. I am really thankful to Dr. Gurbir Singh, sir, with his lot of expertise. He very nicely summarized the maladies faced, the morality, and these are general issues which have also percolated, general issues of the society at large. And medical profession can't be separate from the ills of the society. And that they reflect there also. The ethical concerns. And I always believe when we are talking of making humanities, ethics, as a part of the curriculum. Basically, we are trying to make good human beings. Good human beings in any profession would make them best professionals. Most of the doctors agree that if there is a headache, we are going to give analgesics. But why certain doctors flourish, certain don't? That is because probably they are lacking somewhere in the basic morals. So to make good human beings automatically is going to decrease this problem of violence. Dr. Rajput, with his vast experience across all the sectors, gave a very good insight into the violence. He also mentioned about medical jostling. A loose comment passed on by the nurse or the ward boy or a fellow doctor is very, very important cause of violence and the relatives thinking that something wrong has happened. Here he also mentioned about the Professor Russell gave a global perspective, which is vast experience. He tried to explain that we doctors should understand that the ethical issue of a vertical relationship between a doctor and a patient now has rapidly changed with the increasing level of literacy, information explosion. It has become and need to become a horizontal relationship. The patient concept of patient as an equal partner in his own healthcare. Somehow our egos, our basic training that very often I see my colleagues very wrongly say when the patient asks too many questions, whether you are a doctor or I am a doctor, just shut up. And that small points of conflict, they cause damage to the doctor-patient relationship. And this doctor-patient relationship, which is a very sacred relationship, that trust, erosion of that trust is another major genesis of points of conflict. Various reasons are there. Maybe we'll have to take another convention on it. Dr. Shauli Chaudhary Chakravarti very rightly said about the gender and the social inequalities. Mind well, friends, 50% of the health workforce comprises of women. And there are incidences of violence within our fraternity also. Seniors abusing the juniors in all across all boards. When we talk about violence against the healthcare givers, then this also issue we need to be bold enough to deal with. Dr. Professor Das very rightly, according to his own personal experience and in the COVID time experiences, he joined the about role of counselors, maybe it in the public sector or in the private sector. Dr. Goswami, a senior police officer, very rightly said that this is a social crime. So many social crimes. And while tending to agree that only laws will not solve this problem, but definitely laws definitely act as a deterrent. The issue is again a systemic general issue of implementation of those laws. And there lies in problem. When in 2009, because of the good efforts of Dr. YSR Reddy as the Chief Minister of Andhra Pradesh, were the first state to enact this law, then now at 23 states, what we find is lack of knowledge even to the police officers. In a state like Maharashtra, thrice through the Director General of Police, we have written letters and sent copies of the law existing in Maharashtra. Still, every time a case happens, our local IMA people have to give a copy of law. So basically, implementation is the issue. Intolerance, he mentioned, which is a very good and reality that overall societal intolerance to anything is increasing. That is again reflected here. Lot of things are to be said about corporate culture, how corporatization of health services has damaged the doctor-patient relationship and given a bad name. I see the both sides of the issue. One, that the health costing, which Parag mentioned, which is very important. We at IMA for last 3 years have been doing costing issues, especially when the Ayushman Bharat Yojana came. We have submitted it to the government along with FICCI, AHP, everyone under the umbrella of IMA. Lot of efforts are put in against these costing studies, and but the government is not going to budge. There are political compulsions. What is lacking in the corporate thing is lack of sufficient information, which slowly is improving. Entirely agreed that the amount of cost is so much. And I know so many big hospital chains under a lot of financial strain because the generation of funds is not that sufficient to maintain a hospital. But lack of information. Every day I get a call that, sir, our patient is admitted in Bombay hospital. We just want to know what is the status of patient. Now certain steps are taken, especially the counseling is extremely important. Limitations of law, follow-up of cases, fast tracking of courts, which our dear friend Advocate Bajpai also mentioned. These are all important steps, but again, taking a very holistic view, preventive measures will take long term to act. Making doctors in their medical schools, training them to be good human beings, that also is part of their own upbringing. Your morals, basic morals have to be good. You need to train them to deal with stressful situations. Ethics play a main important role. People like Russell D'Souza World Medical Association are working a lot in getting ethics even to the practicing doctors. Accreditation, yes. Quality, safety of patient, they also play a role in prevention. Anticipation of a problem needs to be taught, but also it comes with the experience that a particular patient, a political person getting admitted, a mob, areas, there are definite areas which a local doctor would know that patients coming from this area more prone to violence. Anticipation of a problem and then try to negate the bad effects. After the problem happens, how to manage it, so many things can be done, how to follow up cases, what the law should be, all these things. But in broad, as very rightly said, somebody also mentioned, Dr. Rajput, I think so, was very vocal about having a blacklist of patients. We at IMA discussed this at various lengths. My brother Ravi Shankar is here. He in fact prepared a software also. But these are a lot of ethical concerns regarding this and to implement it. So that is still under discussion. Broadly, as Advocate Bajpai said, health needs to be taken seriously. And what do I mean by taken seriously? Health needs to come on the political agenda. Health needs to be an election issue in this country. Elections are fought on BSP, Bijli Sadak Pani. It has to be on health. Increasing health budget, yes. But only increasing health budget and not prioritizing that health budget. Say a USA spends more than 17% of GDP, but still ranks 9th in overall indices. Why? Because they have gone into a 100% insurance-based model. Again, I am a very, very vocal opponent of 100% insurance-based model, which damages the sacred doctor-patient relationship. The insurance runs for the profit of its shareholders, not the autonomy of the physician. Autonomy of the patient is lost. Health needs to be included as a basic right enshrined in the constitution separately, apart from the inclusion within the right to life. Unless and until health becomes a priority on the politicians, and this talk that corporates are luteras and they are squeezing patients, that happens because all the politicians, all the lawmakers, all the opinion makers take treatment from these corporate hospitals which are reimbursed. And so they have a fixed yellow goggle into their eyes that yes, all the hospitals are like this. 90% of the hospitals providing primary and secondary healthcare, they are friendly neighborhood nursing homes providing available, accessible, affordable, accountable healthcare. All our doctor colleagues, 90% of them give lot of charity. This is not publicized. It is our duty also as an association need to educate masses regarding medical negligence. It is very easy to say that doctors need to punish for medical negligence. Yes, but one needs to understand that there is a medical accident, there is a medical reaction, and then there is a real medical negligence. Hardly 5% cases come into real medical negligence. Accidents, complications, and negligence we need to educate and go to the community. Lastly, unless and until we take the community along and educate them, sensitize them about all these issues, this issue can't be addressed. Everybody agrees it is a complex issue, multidimensional issue. This today's convention has really worked wonders, going beyond the ambit of our usual doctors association meetings. And I really once again thank and congratulate the entire team of the Dr. Ravindra Mangal. Parag, good job as usual, very crisp, very pointed, and keep it up. Thank you. Thank you.
Thank you, Dr. Wankhedkar. Thank you for your kind words. Appreciate the same. We've received we've received a lot of comments from all our listeners. We cannot represent all of them here due to paucity of time, but we will definitely be taking all of those into account as we start writing the white paper. So, Mr. Mangal, we need to ensure that we are respectful and mindful of all of that. Thank you very much. And as I sign out, I hand over to the Chief Operating Officer of IML, that is Mr. Agasti Matre. Agasti, over to you for the vote of thanks. Thank you very much, all of you, and thank you for the support.
Thank you, Dr. Parag. Thank you so much. That we are come to an end of this event. So, on behalf of Institute of Medicine and Law, I extend my sincere thank you to today's chairperson, Dr. Wankhedkar, and our convener, Dr. Pillai. I am immensely thankful to our moderator, Dr. Parag Ringlani, for moderating this today's session once again so effortlessly. Thank you so much, sir. My gratitude towards all the esteemed panelists who gracing for this occasion and sharing their opinions today. An event like this, it cannot happen overnight. The wheels start rolling about weeks back. It requires planning, bird's eye view for details. We have been fortunate enough to be back in with the team led by Mr. Ravindra Mangal, very proactive, dedicated staff of Team IML, who have done a very good job to organize this event. I thank you again for making this session a very knowledgeable for medical and legal fraternity. Have a happy Sunday, everyone. See you.
Thank you.
It's an institute which has really bothered for the medical community.
The Institute of Medicine and Law. Medicine and Law. For putting on this wonderful show. This will, I'm sure, in days to come, be eye-opener for the government as well.
Justice means which is just for both the parties.
I think IML have succeeded in their mission to a large extent.
The laws are made in the parliament, that's true, but the expertise lies in the periphery or in the country. So this is the real team what I feel. There you can guide us, send a document after this panel discussion to me, and I will definitely see that certain fruitful things will come out of this panel discussion, and we will see the result in Rajya Sabha as well as I will give it to Lok Sabha also.